Okay, this morning we engage with Children's Health Ireland and the National Treatment Purchase Fund to discuss its financial statements of 2023. We welcome the following officials from Children's Health Ireland: Ms. Lucy Nugent, Chief Executive, Children's Health Ireland; Mr. John Fitzpatrick, Interim Chief Financial Officer, Children's Health Ireland; Ms. Ailish Hardiman, Strategic Programme Director, Children's Health Ireland; Ms. Julia Lewis, Transformation Director at CHI; Ms. Paula Kelly, Clinical Director C at CHI. We also welcome the following officials from the National Treatment Purchase Fund: Ms. Fiona Brady, NTPF Chief Executive Officer; Mr. Don Gallagher, who is the Chair at the NTPF; Mr. Sean Flood, NTPF Director of Finance; and Ms. Bernadette Weir, NTPF Director of Commissioning. Finally, we were joined by officials from the Office of the Controller and Auditor General, including the Controller and Auditor General, Mr. Seamus McCarthy, who is a permanent witness to the committee, and Ms. Paula O'Connor, Deputy Director of Audit. You are all very welcome this morning. I also wish to explain some limitations to parliamentary privilege and the practice of the Houses as regards reference you may make to other persons in your evidence. The evidence of witnesses physically present or who give evidence from within the parliamentary precedents is protected pursuant to both the Constitution and statute by absolute privilege. This means that you have an absolute defence against any defamation action for anything you say at the meeting. However, you are expected not to abuse this privilege, and it is my duty as Cathaoirleach to ensure that this privilege is not abused. Therefore, if your statements are potentially defamatory in relation to an identifiable person or entity, you will be directed to discontinue your remarks. It is imperative that you comply with any such direction. Witnesses are also reminded of the long-standing parliamentary practice that you should not criticise or make charges against any person or entity by name or in such a way as to make him or it identifiable, or otherwise engage in speech that might be regarded as damaging to the good name of the person or entity. Therefore, if your statements are potentially defamatory in relation to an identifiable person or entity, you will be directed to discontinue your remarks. It is imperative that you comply with any such direction. I will ask Mr. Seamus McCarthy, the Controller and Auditor General, to now make his opening remarks.
The National Treatment Purchase Fund Board has responsibility for the management of a range of activities within the healthcare system. Its main activity comprises identification of and payment for treatment or assessments to assist in reducing inpatient and outpatient waiting lists in public hospitals. The Board also has an important function in assessing and approving the scope and level of charges for long-term care in private nursing homes for persons availing of the Health Service Executives Fair Deal scheme. The Board's financial statements for 2023 record an effective break-even situation with total income and total expenditure of just over €190 million. Almost all of the Board's income comes from Vote 38 Health. The Board's income and expenditure have both grown rapidly in recent years. To illustrate this, the Board's expenditure in 2023 was almost 3 times the expenditure of €64.8 million incurred in 2019. The Board secures treatment and assessments for waiting list patients in private hospitals and in public hospitals which offer spare capacity to provide required patient care. In 2023, payments made to private hospitals amounted to €107 million, while payments to public hospitals amounted to €72 million. This represents reliance of 60% on private healthcare providers and 40% on public healthcare providers in 2023. Note 3B to the financial statements analyses the payments by medical specialty, indicating the range of areas where care is purchased. Payments to individual hospitals are not shown in the financial statements. The Board's payroll costs and other administrative expenditure amounted to €11 million in 2023. Included in this are costs of just over €1 million in respect of the Board's price negotiation function with private nursing homes. I issued a qualified audit opinion in respect of the agency's financial statements for 2023, but only in respect of the accounting treatment of retirement benefit liabilities for the board staff. This is not in line with standard accounting practice, but it does comply with the accounting directions of the Minister for Health, which are common to a number of health sector bodies that I audit. The 2023 financial statements were certified on the 30th of September 2024. Members may wish to know that I certified the financial statements for 2024 just last week. I understand the process for presenting those financial statements is in train with the department. I outlined the key financial results for the 2023 year of account when the representatives of Children's Health Ireland were last before the committee on the 22nd of May, and I do not propose to repeat that presentation this morning. Since the meeting of the 22nd of May, details of an internal examination undertaken by Children's Health Ireland in 2021-2022 have come to public attention. As I've previously explained to the committee, my office was not provided with a copy of that report at the time it was finalised, or when the audit of the hospital's financial statements for 2021 was being undertaken. My office has in recent weeks received a copy of the report. While the main focus of the internal report is on personnel management concerns in relation to a clinical department in part of the hospital, it also raises some concerns around a number of financial risks, including around the controls over claims in respect of care paid for from the National Treatment Purchase Fund. Because of the report findings in regard to those financial risks, the hospital should have brought the report to the attention of the audit team in the course of the audit of the 2021 financial statements. The control implications of the report's findings will now be considered as part of the audit of the hospital's 2024 financial statements, which is currently ongoing.
Thank you, Mr. McCarthy. We will now move to the opening statements of the other witnesses as set out in the letter of invitation. You have 5 minutes to make your opening statements. I now ask Ms. Lucy Nugent, Chief Executive, to make her opening statement on behalf of CHI.
Thank you, Chair, and good morning. Thank you to the committee for the opportunity to again address you and give you a further update on work that is happening across our children's hospitals and commissioning programme for the new Children's Hospital. As you know, I'm Lucy Nugent, I'm the CEO of CHI, and I'm joined by my colleagues, Mr. John Fitzpatrick, Interim Chief Financial Officer, Ms. Julie Lewis, CHI's Transformation Director, Ms. Eilish Hardiman, Strategic Programme Director, and Ms. Paula Kelly, Clinical Director. I'm now 5 months in this job, and despite the various challenges that we have had, and I will speak to those later, I want to reiterate that I am proud to represent our almost 5,000 staff who work diligently at the front line of paediatric healthcare provision in CHI at Temple Street, Crumlin, Tala, and at our Urgent Care Centre in Connolly. Across 39 specialties, we provide exceptional care to children and young people in old buildings not fit for purpose. We continue to lead on paediatric research and innovation on an international stage because, as I've said many times before, our children and young people deserve the best that medicine and science can offer. When we discuss the challenges and mistakes of our organisation, let us not forget the remarkable work that our staff do to care for children, young people and families every day. In regard to recent clinical issues raised, I would like to again acknowledge and give full recognition to the families who were impacted by the recent HIC report, the DDH report and the unpublished internal report. On all of these issues, on behalf of CHI, I wish to apologise unreservedly. Children, young people and their families were failed, and we need to rebuild trust in CHI. I want to speak briefly to the issue of publication of the various reports and the suggestion that CHI has been evasive in reporting or commenting on these issues. CHI is a statutory body and must respect the legal advice we receive, not to mention the moral imperative to protect the confidentiality of patients. We also have a duty to see that matters are properly investigated and due process is carried out. This can sometimes mean that we cannot comment on matters, even if they are reported in the media or elsewhere. This does not mean that we are not mindful of the great upset that such reports cause parents and children and the gravity of the issues. But I want to assure members that this is never the intention. Our intention is always to ascertain the facts and take steps to fix the issues, whilst at the same time telling parents and children what we are doing. In my first 5 months, I have worked with the board and my executive colleagues to enhance our governance structures and stabilise the executive management team with the hiring of a permanent Director of People and Culture, Deputy Chief Executive Officer and Chief Operations Officer. The recruitment of a Chief Finance Officer and Director of Quality, Safety and Risk Management has commenced. I am delighted that these high-calibre new colleagues have chosen to join CHI. In relation to recent reports regarding CHI and the National Treatment Purchase Fund, I would like to update deputies. There was some misunderstanding in media reports in relation to NTPF payments to a CHI consultant. I can confirm that the clinics at the centre of the reports did not take place in the consultant's private rooms. They occurred in a public clinic in one of our hospitals on a Saturday. It was a waiting list initiative for an outpatient appointment only. A longer-term sustainable solution for referral management was put in place and the rollout of this system is ongoing. All services will be on the central referral system in the coming months. In relation to the new hospital, CHI will move into the newly named National Children's Hospital Ireland. In May, we updated you on plans to undertake a programme of commissioning to see our services finally move into a building worthy of the children of Ireland, operational to international standards. For the last 6 years, we've been building our own organisation for that moment. We are integrating teams, we are integrating our ways of working, and we are integrating and improving our culture. This is complicated, difficult, but vital. And in conclusion, CHI fully acknowledge that we have fallen short of the high standards children and families deserve. We are deeply sorry for the harm and distress caused. We want to do better, and we are committed to building an organisation defined by openness, compassion and learning. And as a learning organisation, we will take inspiration from leading international children's hospitals. We have demonstrated that safety and trust are built on 3 pillars. A culture of continuous learning and development. We will create an environment where every staff member feels safe and supported to speak up when things go wrong and where we act quickly to learn and improve. We want a true partnership with children and families. We will put children and families at the centre of all decisions about their care. This means working with parents as equal partners, ensuring they are informed, respected and empowered to shape services. We want transparency and accountability. We are committed to being open about our challenges as well as our successes. We will publish regular updates on our progress in reducing waiting lists, improving outcomes, safety and strengthening our governance. We recognise that rebuilding trust will take time, but we are determined to ensure that every child who comes to CHI receives the safest, most innovative and compassionate care possible. We will get there, and CHI has the determination, the skill, the ability to see this project to the new hospital to completion and beyond. Thank you.
Thank you for that, Ms Nugent. I will now ask Mr Don Gallagher, Chairman, to make his opening statement on behalf of the National Treatment Purchase Fund.
Thank you, Mr Chairman. I'd like to thank the Public Accounts Committee firstly for today's invitation to discuss the NTPF's role as part of Ireland's public health system. By way of my personal background, I was first appointed to the NTPF board in March 2021 and became chair in July of that year. I was reappointed as chair last March for a second term. I am an experienced chief executive who most recently managed the Health Insurance Authority before retiring, and have served on the boards of both state organisations and international insurance companies. I'm joined by the NTPF CEO Fiona Brady on my right, who was appointed to the role in July 2023. Ms Brady was previously CEO of Our Ladies of Lourdes Hospital in Drogheda and Louth County Hospital for 5 years, and has first-hand knowledge of the workings of the acute hospital system relating to both scheduled and unscheduled care. As you will be aware, and as already mentioned, the NTPF has 3 key responsibilities. Firstly, commissioning inpatient and day case procedures, outpatient appointments, GI scopes and diagnostics for the longest waiting public patients. Secondly, collecting, collating and validating public hospital waiting lists. And thirdly, negotiating the maximum price of long-term residential care under the Fair Deal scheme. This is a vitally important task in terms of both the nursing home resident and for national finances. And the NTPF concluded 300 negotiations with individual nursing homes last year. For the purposes of today's meeting, I will focus on the NTPF's commissioning role as part of a multi-agency strategic approach to improve health outcomes for patients, explaining our approach and impact. I will also address the actions the NTPF has taken in recent weeks following allegations of misuse by public hospitals of its funding provided for approved insourcing initiatives. On the commissioning front, the NTPF ensures public patients get faster access to timely care through insourcing arrangements with public hospitals and outsourcing arrangements with private hospitals. Outsourcing arrangements involve the NTPF procuring treatment and care for public patients in private hospitals. Every year, private hospitals tender to offer care across a wide range of specialities. We select the hospitals with available capacity and suitability of location, giving the NTPF options to offer treatment and care across almost all specialities, from cataracts to hip replacements and scopes to first-time consultations. We review hospital waiting lists regularly, enabling us to identify the longest waiting patients for certain specialities. Working with a referring public hospital, we offer patients the option of treatment or care in a private hospital. The welfare of the patients is almost of the utmost importance, with only patients confirmed as clinically suitable for outsourcing by the hospital who are offered treatment. Patients themselves must also agree to the treatment. If a patient declines the offer, we will call them to see if there's anything we can do to make the treatment offer a possibility for them. The patient will always receive a full episode of care. For example, if they have a knee replacement, we will arrange a full programme of follow-up physio and follow-up consultant reviews at the same hospital. Only when the patient is fully discharged and is payment made to the private hospital. And importantly, the NTPF pays the treating hospital, not the consultant. Outsourcing with private hospital accounts for about 70% of our commissioning work. The remaining 30% is focused on insourcing initiatives, which have been at the centre of recent media discussion. Insourcing is where the NTPF provides funding directly to the hospital, to the public hospitals for treatment or outpatient consultations seen outside of core activity, that is additional to the activity funded by the HSE. Insourcing means we can maximise the existing resources within the public health system. The process involves senior management in public hospitals applying to the NTPF to secure funding, outlining their opportunity to get long-term waiting patients, long waiting patients treated faster and provide a specific treatment plan and solution. The application is reviewed by our commissioning team and then forwarded to the NTPF senior management for approval. The NTPF has a strong financial oversight procedures and processes in place to administer insourcing funds. It only makes payments in relation to specific named patients who have been on a public hospital waiting list, and only then on receipt of detailed invoices from the public hospital confirming that care is fully complete and the specific named patient has been discharged. Payments are only made again to the hospital and never to any individual consultant or staff member. Importantly, internal governance and the management of the insourcing work remains with the referring public hospital, with the agreement under the NTPF's Memorandum of Understanding that funding is used as specified and as agreed. The impact on the patients. The NTPF's approach to commissioning frontline care has been overwhelmingly successful in ensuring public patients get access to quicker treatment over the last number of years. Since 2019, the NTPF has arranged surgery for care for almost 1 million patients, helping the system move closer to sláinte care waiting times targets. Over the last 2 years, almost 500,000 public patients received their surgery, consultant appointment, scope or diagnostic scan faster because of the NTPF. Last year, the NTPF exceeded its patient treatment target set in 2024 waiting list action plan by over 10%. And again, this year, it is ahead of its set treatment and care targets for 2025. Last year, NTPF activity between commissioning and validation accounted for the removal of over 317,000 patients from the scheduled care waiting lists. Turning to the allegations of misuse of funds, the NTPF and its board have been deeply concerned by recent allegations of breaches of its processes by public hospitals concerning insourcing initiatives. The NTPF first learned of the internal Children's Health Ireland report outlining the misuse of NTPF money at CHI through the media. We immediately placed a temporary pause on all insourcing work with CHI and initiated a review of this work. Both parties worked closely together and on receipt of the appropriate assurances by CHI management and confirming its ongoing compliance with existing NTPF procedures, we recommenced insourcing work. The engagement of the CHI senior management and CEO, Ms. Lucy Nugent, greatly expedited the process, thereby minimising the impact on patients. Upon learning of potential issues in relation to NTPF-funded insourcing work at Beaumont Hospital, the NTPF immediately suspended all insourcing work and payments at Beaumont and informed the Department of Health and the HSE of its concerns. HSE Internal Audit is currently carrying out a detailed review of Beaumont. We are ready and we are willing to recommence insourcing once we receive the necessary assurance regarding the appropriate use of NTPF funds. We are working closely with the HSE, with the HSE Regional Executive Office on this matter. The public must have full confidence and trust in the insourcing process. We are working alongside the Department of Health and the HSE to increase governance and oversight across our insourcing work with public hospitals. As part of the process, the NTPF CEO has already written to all hospitals who participate in insourcing initiatives funded by the NTPF to seek assurance of full compliance with our MOU. We are now assessing the responses received and will provide a comprehensive report to the Department of Health and the HSE. Looking to the future, the Board and the Executive of the NTPF take the responsibilities to the public taxpayer very seriously. We will take whatever actions are necessary to ensure our spend is fully protected for the benefit of the public patients and the taxpayer. While waiting lists remain a challenge for the general hospital system, our priority for the remainder of the year is to continue to work with the Department of Health and the HSE to get long-waiting public patients access to treatment and care and keep overall waiting times as low as possible as we continue to work to achieve our Sláinte care targets. Thank you very much.
Thanks for that, Mr. Gallagher. Now we move to our speakers, and just to note that we will suspend at approximately 12 o'clock for a short break and resume shortly thereafterwards. I'll now open the floor to members. The speaker today is Deputy Grace Boland, who has 15 minutes for questions and answers. All other members will have 10 minutes, and if time permits at the end of that, I will allow members to come back in for a second round. So we start off with Deputy Boland.
Thank you all for attending here today. While at this committee we tend to focus on figures and finances, we need to remember that behind every number is a child, a patient, a family, a story, and we can't lose sight of that. Ms Nugent, I really do welcome your comments here today about wanting to do better, putting children first, putting families at the centre of decisions, and communication is really key to that, and we need to see improvements on it. I understand that you've accepted the DDH audit findings and that there's obviously a review underway of patients, and that your position is that review is comprehensive. I suppose I've been contacted by several constituents with queries and concerns in relation to the review. And one example is a mother who has recently contacted me. She has two daughters, one age 7, one age 5. They both had the surgery within the last couple of years. One was done in Temple Street and one was done in Kappa. One of her children has been included in the review and the other child hasn't. And she has tried to get answers as to why the other child hasn't been included in the review, and the response she got was because her other daughter actually has additional health issues, and therefore she's been excluded from the review. Now, to my mind, that's a child that's actually more vulnerable and should absolutely be included in the review. And I'd like you to please confirm to me, is that actually the case? Has there been an error here? Or can we be certain that every child has had this surgery is actually included in the review?
Deputy, I'm very happy to get the name of that family afterwards and look into it for you. 2,259 children, families were written to in relation to this audit. And if that family wants their child reviewed, I don't see any reason why we couldn't include them. But I will certainly be very happy to revert to you in that regard. Some children have ongoing long-term surgery management in relation to additional comorbidities. That may be the reason. I may defer to my colleague, Ms Kelly, in regard to that to provide further information.
Yeah, I suppose I don't want to use a child who has a very complex need being filtered out of a review, because that is actually the opposite of what we should be doing.
So I can probably answer that. So the audit only included children that had stable hip dysplasia and no other comorbidity. So the audit only included those children. So children with other associated comorbidities were not included.
But every child has the right to safety. Every family has the right to have peace of mind as to what has happened here. And actually, if complexity is being used as a filter, that's just discrimination.
The initial concern was raised around children who had Salter's osteotomies for hip dysplasia without any other comorbidity. Obviously, if concerns comes up with children with other comorbidity, then we would absolutely look at that.
But she wasn't contacted at all in relation to her second daughter. So she's, like her and families like her, are left in a vacuum. And we're, children who really are more vulnerable are not being included in the review. I just find that
The initial
baffling.
report only included children with no associated morbidity.
And will that be looked at?
I suppose that would have to be looked at once the full examination of the current children that are under review is, once the results of that are through from the HSE, is committed to a full review of of children who have had hip dysplasia surgery.
Have those families who have not been included in the review, have they been written to, have they been communicated to and offered the opportunity to be included in the review?
Not to the best of my knowledge.
And I've previously stated in the Joint Oireachtas' Health Committee there 2 weeks ago, if there's any family who feel that their child should be involved in the review, we're very happy for them to contact us. The details are on our website and we will follow up with them.
I appreciate that, but it doesn't just scream a patient-centred approach to me. Like, I do have an issue with that. And again, the lack of communication with the families. Some families may not even fully realise, and I really do think that there needs to be much more communication. This family, and this is only one family that has come to my attention in the last couple of days, I really have serious questions about this and concerns, and I just don't think it's good enough, to be honest with you. If we're looking at a patient-centred approach, I think we need to do better, and I really would urge you to do that. In terms of the consultants who are involved in the surgeries, particularly in Temple Street and Kappa, are all of those still employed and working
Yes.
with CHI Fund? Okay. Have any issues been referred to the Medical Council, or has there been any assessments done at this stage?
So we are in a process of, first of all, the most important thing in the beginning was to actually review the children and make sure that they are all right and the status of them.
Some of the children.
And then the second element of it is the expert panel that the HSE are setting up and commissioning to assess the decision for surgery in that regard. So until that process is completed, we will have to see the outcome of that.
Okay. In terms of the NTPF, clearly it has played a vital role in tackling waiting lists, removing over 317,000 public patients from waiting lists. And obviously, in light of recent revelations, it's important that we take a closer look at how the funding has been applied. No less than 3 hospitals have had funding ceased due to concerns in relation to misuse of those funds. I see that the Minister and Bernard Gloucester very much are hoping to remove insourcing, although the funding that has been going into insourcing, if I read the accounts right, has only increased over the last number of years. I suppose it's hard to wade through all of the information that we're being given and the media reports. But are there more than 3 hospitals that have been flagged in relation to potential misuse of NTPF funding?
Thanks, Deputy, for that. So you're aware of the Beaumont issue and you're also aware of the CHI issue. And just to say, in light of yesterday's Health Committee, Naas General Hospital was mentioned yesterday. The NTPF did not cease funding for Naas General Hospital. They had full disclosure with us, with the HSE and with myself. And of their own volition, they decided that they would cease all insourcing temporarily while they waited on Mr Gloucester to send in the HSE internal auditors to review. So we did not cease funding, they did it themselves.
And have any other hospitals flagged such issues?
So, as Mr Gallagher mentioned earlier in his opening statement, I carried out, after the issues in relation to Beaumont and CHI, carried out a national assurance review. That's due to close tomorrow evening. There are 2 hospitals that we have sought further clarification on, and they have to close the business tomorrow to provide that clarification. And then I'll be providing a full and comprehensive report to the Department of Health and to Mr Gloucester.
I have to say, I found the idea of insourcing and the prolonged use of it actually baffling. It took me a while to get my head around the fact that we were actually paying people in the HSE, not just overtime rates, but we were actually going around the system using HSE facilities and actually paying them a huge premium to come back and do work on at the weekends or through the NTPF. I really would like to see that the insourcing model is phased out over the next couple of years, and I note the Minister's comments in relation to wanting to see it phased out very quickly. In terms of the money given to private and public hospitals, as the Comptroller and Auditor General highlighted, it isn't clear which hospitals are at the top in terms of being funded through the NTPF for public or private. Can you tell us what the top 2 private hospitals and the top 2 public hospitals are?
Yes, we have that information, Deputy. I might hand over to my Director of Finance, Mr Flood, there.
Thank you, Deputy. The top 2 private hospitals would be Kingsbridge in Northwest, which is in Derry, and the other Kingsbridge Hospital in Belfast, were the top 2 for last year in terms of payments.
Private hospitals?
Yes.
And public?
Public, the CAPA and the Mater.
And what kind of surgeries are happening up north? Well, what's the nature, generally, the nature of the surgeries that are happening there? Do we know?
That's brilliant.
I'm just wondering why we're going up to Derry.
So they're doing a range of surgeries for us. They're doing a range of initiatives. So they're providing outpatient appointments for us across a range of orthopaedics, general surgery, gynecology. That's just a flavour of it. And then the follow-on surgery, if that is required.
And is that arrangement on an annual basis? Or do you have a contract for a period of time?
So what we do is we have established a panel of hospitals, and that normally runs for 3 to 4 years. And then we tender for procedures on an annual basis.
On an annual basis, okay.
Deputy, might I just add further
Very
clarification?
quickly.
Very quickly, so we have an all-Ireland approach to how we manage waiting lists, and Dublin and the Midlands are well serviced for private hospitals, but the west of Ireland isn't, and that's why it's really efficient to use Kingsbridge for those patients, just so nobody is disadvantaged.
Thank you. Ms Nugent, the NTPF first found out about the alleged misuse of the NTFP funds through the media. Why didn't CHI raise this issue with the NTPF?
Well, as I said earlier, this is a report that was done in 2021, 2022, and while the allegations and statements were unsubstantiated, in hindsight we should have engaged with both the CNAG and the NTPF in this regard.
And then in terms of the consultant who was deemed medically unfit to do on-call hours but was flying through patients on a Saturday, can you tell us, is he now working on-call hours?
So I suppose just to clarify, the individual was reviewed by the Occupational Health Department and was deemed not fit to do on-call. This really doesn't mean about doing daytime hours. It's really about if you get a call in the middle of the night to operate on a sick baby or to go and treat a sick baby, you need to be in the full of your health. So that's the element of on-call that was the issue. So they were fulfilling their normal daytime hours in that regard.
Except we were paying for a locum to cover the on-call hours, and then he was obviously getting additional payments for working these Saturday clinics, which were funded by the NTPF. So the taxpayer has been hit on every side, which doesn't seem very efficient or value for money.
Except the individual would not have got their on-call payment because they weren't working those hours, so it would have been cost neutral in that.
But we were paying more to a locum to cover the on-call hours. So again, are there any other consultants in that position who aren't doing on-call hours? Would we have a figure?
I wouldn't have a figure at the top of my head, but it would be, there would be, if someone's returning after having surgery, they would have a period where they wouldn't be on call, etc. But we have an occupational health department who would sign off and review all of those cases, and our clinical directors would be aware of them to support the individual back to full hours and on call.
The NTPF funding, is it incentivising workarounds where core public duties are deprioritised in favour of better paid in-source clinics?
The first step that we take when we're considering an NTPF proposal is to ensure that core activity is maximised. That's the first step. So it is about making sure that we fully utilise both our outpatients and theatres, etc. We also now have a central referrals office, so referrals come in through that and they are equitably distributed amongst specialties, so we don't have huge variance in waiting lists per consultant. However, there will always be some variance where a specific specialised service may be needed in one particular department, and only maybe one or two of those colleagues could do that.
Okay. Do we think that the patients who've been waiting the longest have been deprioritised, or in? No.
No, we prioritise our
okay.
waiting list in relation to clinical need.
Yeah.
Unfortunately, it does mean that some of the lower complex conditions may be waiting longer, and that is obviously a concern.
The last time you were in, Ms Nugent, I highlighted 8.4 of the Code of Practice for Governance of State Bodies, that is not to enter into NDAs which precluded from disclosing details of settlements reached in financial statements, save in exceptional circumstances and on foot of legal advice. And I had asked you to provide us with the grounds on which the grounds on which the legal advice was provided that you have decided to enter into an NDA with the former CEO. Can you tell us here today now what those grounds were?
I might defer actually to Ms Hartman herself in that regard.
Thank you, Deputy. In relation to, this is an employment law matter, and obviously the Board of CHI can appoint the CEO with the approval of the Minister for Health. The Board in October 23 sought for a third term after my two previous consecutive 5-year fixed-term contracts. It is government practice and policy for non-commercial state board CEOs to be appointed for 5-year terms with no more than 2 concurrent terms. The Minister did actually apply that policy, which is obviously within his right to do, and that was accepted by the board. Because it was an employment matter, because it was 2 fixed terms, the contract automatically became a contract of indefinite duration. The board then determined that there were some strategic projects that needed to be prioritised, given that the new Children's Hospital is progressing and soon.
Sorry, I'm actually running out of time. I appreciate your answer. But in terms of the NDA specifically, why was it deemed that we needed to have an NDA? And if there is no issue or nothing to hide,
I don't think there's a great issue, to be quite honest, because I wasn't.
Both you and CHI could waive it.
I wasn't CEO at the time that was done, and there was agreement in a mediation process of which is covered.
And would you be happy?
Confidence,
you can both waive the NDA so that we have full transparency in relation to any settlement.
There are 3 parties to the NDA.
All 3 can waive it. If the NDA isn't required, it can be waived.
Yeah.
If there's nothing to hide.
I don't have anything to hide, Deputy.
Thank you.
Thanks, Deputy Boland. Our next speaker is Deputy Connolly.
Mark the Cahir Lucas, Fulcher of Galer. You're all very welcome, and I really appreciate it. It's important that we have trust in public bodies, and I'm a firm believer in public bodies, and also doing the best we can, which is not very good in 10 minutes to hold you to account. But I have read all of the documentation. I realise the volume of patients that you put through your hospitals on a regular basis, every day, every year, and also the staff. However, I'm going to deal with CHI first and then come to the NPF as best I can. Ms Nugent, you were here on the last occasion and you talked about openness and accountability, and I went back on your statement, and I'm not going to be personal in any way, but honestly, I have no idea how you didn't highlight the internal report from 2021-22. Why didn't you do that?
That's the unpublished report that I referred to in my statement.
I'm just asking a specific question. You know well which report, and it wasn't referred to you. You didn't refer to it. I have it here in front of me, and we've got a summary of it, and we've got a legal opinion. I'm not going into any of that. I'm asking you why you didn't refer to that report when you were before us.
The last time?
Yeah.
Sorry, I didn't know about it.
You didn't know about it at all?
No.
When did you find out about it?
I found out about it when the media query came in.
Okay. Well, that's very significant, really, isn't it? Because, I mean, we've all read the report as best we can, and it's absolutely damning, the bits we see in terms of culture. I haven't the time to read it out. You can take it that I've read every single bit of it. Multiple legacy and deep-rooted issues existed, but they weren't addressed, and so on. 2 senior examiners were appointed. Who can tell me about that report and why Ms Nugent wasn't informed about it?
I suppose it was originally a HR report.
No, if you didn't know about it. So is there anyone here that can tell me why Ms Nugent didn't know about this very important report? Sardiman?
To answer that, I think this is because I think a lot of the issues that were raised in that report had been addressed. That would be. So many of those issues were actually resolved and repeated.
You obviously had handover period in relation to Ms Nugent. Was she not informed about all these legacy issues and some of them ongoing?
Yeah, I think we were just starting, actually, to be quite honest, and in relation to that, and I wasn't in the CEO position since October 2023.
So there was somebody acting as the
somebody
CEO,
else in
and so why didn't it happen with that person?
I can't
Yeah,
comment on
you
that.
see, honestly, I want to stand reassured, but I don't take reassurances. Do you know what I do? I take the reports from the Controller and Auditor General, any staff, and we read them, and then we highlight what's been highlighted to us to get reassurance that the procedures and practices are in place, not just in place, but are working. Clearly, they weren't working. Clearly, they weren't working. And there's nobody here today to tell me why the new CEO wasn't aware of this report, which has ongoing consequences. So even the NTPF is mentioned in that. And you didn't highlight that. You didn't know about it. It takes the media and it takes all of this. I'm just going to park that for the moment, except it's a shocking report. I'm not going to enter whether it should be published in full, because what I have is utterly shocking. Even the training was stopped. The culture was so toxic. So how can you have openness and accountability, a high turnover of staff, no trainees allowed, trainees stopped, and a bullying and toxic culture, and you don't know about that? You're not made aware of it and so on. Really. How many reports are there now arising from that toxic culture and that failure for governments? I'm going to help you. We have lots of internal reports. Then we have HIQA. Then we have the one on the unnecessary hip surgery, the word I can't pronounce. We're waiting on a third report, isn't that right? What's the nature of that report?
That's a HSE commissioned report called the NIAGAM report in relation
When is that
to...
coming?
It's a HSE commissioned report, so I
Okay.
don't have the time.
What's that on?
That's on a review of spinal cases done by a Pacific surgeon.
So wouldn't you admit, given those reports, all the internal reports, not to mention the NTPF, which we're coming back to, and another internal report there, something is seriously amiss, notwithstanding the great work that's been done. And I want to acknowledge that HIQA said there was a burden on management that wasn't tolerable. They're my words, but paraphrasing it. I want to acknowledge all of that. But in the meantime, this is the legacy. Unnecessary surgery being done, delayed spinal surgery, and implants going in that weren't. Okay. You all agree that this is simply intolerable, unacceptable, and the procedures have utterly failed. So you come here there to reassure us, and you're not aware of it. So it's difficult to get reassurance from that, isn't it?
I suppose just to reassure you, in the handover I had from the previous interim CEO, they did highlight cultural issues and challenges, and that's why it is a focus for us moving forward.
Okay. So I understand that you carried out a review in 24. Did you an external review of the effectiveness of the Board of Management?
That would have been the Bob Semple report.
I beg your pardon?
Yes, there was a review done.
Was that by somebody outside?
Externally, yes.
External. What did that cost?
I don't know. I don't
No?
know.
Anybody know? No? Okay, you might come back and tell us. How many recommendations?
There were a number of recommendations in relation to, I suppose, housekeeping.
How many recommendations?
I don't know. I didn't
Okay.
see the full
You see,
report.
these are the things that reassure us, honestly. You tell us the report, you tell us what the recommendations are, you tell us what is the status of the recommendations and their implementation. That's what's very helpful. Your financial statement says an external report should be carried out every 3 years. Has that been done in the past? Every 3 years of the board's effectiveness?
Yes, they've had annual internal.
No, external.
And then external ones every 3. I'd have to know.
That's okay.
which
So
one, but
maybe,
I
again,
believe
that
so,
would be
yes.
very helpful for us to say, look, we've carried out an external report as per our duty and obligation, and we've done it every 3 years. These are the results, and that's not coming from you. That's not coming from you. We're going through all of this, and it's not coming from. I'm just watching the time, so I'm going to the NTPFA. Are you planning for your own demise?
Well, ultimately, Deputy, you're absolutely right.
Are you planning for your own demise? And when are you planning for it? And what steps are you taking?
I'll hand over to Ms Brady in a minute, but
Yeah.
ultimately the plan is that our game plan, if you like, is to reduce waiting lists to the extent that eventually the HLE
I know that.
won't need us.
You're in existence a quarter of a century. Obviously, not you, there's something wrong. You're simply implementing government policy. I'm not absolutely criticising you at all. I'm going to go back to some constructive criticism in the failure of your procedures to detect what was going on. But you're there implementing policy. Presumably it was supposed to be a short-term measure. Quarter of a century later, it's rising exponentially, isn't it? The costs and the numbers availing of it. Maybe you mightn't agree with the word exponentially, but it's rising.
It is rising.
Okay, all right. So the Minister has clearly said she wants to reduce this. Has she been in touch with you in relation to that?
We've had a meeting.
Good.
Had a meeting.
Will there be
earlier this
follow-up
week, yes.
meetings then to plan that you'll no longer be necessary at what point in time?
Well,
That hasn't happened yet?
No, it hasn't
No,
happened yet.
okay. All right. In relation to your own review of the board effectiveness, you had a review of your effectiveness as a board. What were the results of that?
The results that we do this every year.
Yeah.
And
What issues, if any? I mean, do you get a clean bill?
there were no major issues emerged.
Any minor issues? You know, just you do a review of a board to find out what the issues are. What are the issues?
We do,
Yeah.
and the issues are always have been around the degree to which we devolve responsibility to the CEO and the management team. I mean, is that the right balance, for example?
Okay. Did any issue come up in relation to how money was being spent from the National Treatment Purchase Fund in hospitals? Did any of that come up proactively from your review or from your internal mechanisms?
No.
No. Do you think that's acceptable? You know, when you reflect on that as a board, do you think there are some issues there for you? From your Audit and Risk Committee, from your Patient Committee? No issues emerged there in relation to any of these issues?
In relation to the issues that are current out there now, no.
But that's a cause for reflection, isn't it? You learn from the media, is it, about the difficulties with the funding and how it's being used?
We are concerned with the implications of our memorandum of understanding and how that works, absolutely.
I understand, and I read that. There's more than one, is there? Or else I have repetition. Is it one memo of understanding? Or is it
We have a memorandum of understanding with each hospital.
Yeah. And so how were you... Obviously it wasn't complied with, isn't that right, from what we know?
Absolutely.
Okay,
Yeah.
and so now we have a review going on by the Health Executive trying to find out in relation to hospitals and how widespread this is. Now, if I go back to Ms Nugent, you took great care to tell us that the media reports were wrong and to tell us that this didn't happen in a private clinic. Personally, it's immaterial to me. What is important is that the consultant was doing this in a private clinic and in a clinic on a public hospital privately. You see, you're shaking your head.
Yeah,
so just
sorry.
let me simplify it for me. So public patients are seen by a consultant on a Saturday through the National Treatment Purchase Fund. Isn't that right?
Organised by CHI operations, involving other CHI staff like nursing and administration.
That was one of a number of consultants, wasn't it?
Yeah, I mean, we would have quite a number of clinics.
And were the other consultants involved in that work on a Saturday?
We would have varying clinics going on Saturday. In this individual Pacific clinic from the report, it was one consultant who did 5 clinics.
Thank you, Chair.
Our next speaker is Deputy Byrne.
And thank you for all the witnesses for joining us here today. Ms Nugent, there's a lot of apologies issued in your opening statement, and you have said sorry a good few times to families affected, which of course, is needed due to the trauma of the scandals that have come out. But I suppose the test of them sorries will be the lessons that are learned going forward. I note to a previous colleague, you've admitted here today that in hindsight you should have consulted with the CNAG and at the NTPF on the unpublished report. But you have claimed that the HSE were aware of the existence of this report since March 2022, and the HSE have denied this. As recent as yesterday at the Health Committee, Bernard Gloucester, the head of the HSE, firmly denied it. It's his view that this was never brought to the attention of the HSE. So I guess what I want to ask you is, how have we got a situation where CHI can say they sent on this very serious report with very serious issues in it, and I think Mr Gloucester has accepted there's very serious issues in it. You claim you sent this back in March 2022, yes, yet there's no evidence of this. So I'm asking you today, can you provide evidence of this?
So this was discussed at the Performance Management Review monthly meeting in March 2022, but I'll hand over to my colleague, Ms Hardeman, in that regard.
Thank you, Deputy. I think, for starters, the position we were taking is that this report was never intended to be shared. So
Look, I accept that, and I'll come to that in a moment, and we are tight on time. Can you provide evidence?
I am able to say to you, though, the issues that, because it was been happening in 2021, the matters and issues in the report were known to management, and they were raised with the HSE through the appropriate channels, and several of those were done before the report was finalised. So while the report itself wasn't shared because it was confidential and regarded as that, what's most important here, particularly around the patient safety matters, they were raised through the appropriate channels, and thankfully, and we worked with the HSE to address the key risk issues involved.
So we're saying clearly today that the information that was originally put out is incorrect, that this report
No, I'm trying to be really accurate here.
No, I understand what you're trying to say, that issues
The report was never intended to be shared, so it hadn't been shared at the time. But the matters in the report were brought up through the relevant those issues, and they were brought up in 21 and 22.
We can take from that what it is. Coming back to Ms Nugent, sections of this report have been referred to the Gardaí for potential misuse of public funds, and it was the HSE who actually referred this. CHI did not refer the report and sat in it despite the timeline being outlined here going back to 2021. You never sought an opinion from the HSE or the department despite clear evidence of unnecessary clinics and thus misuse of public funds, which happened in CHI Crumlin. And it seems even after the HSE sent a report to the Gardaí, the CHI has continued to oppose this. I think it was mentioned that it didn't meet the threshold. Is that correct?
And we respect the HSE's position on examination in relation specifically to the unsubstantiated statements in that report. They were investigated. As I said, the actual clinic proposal to the NTPF was done by the operations team based on the fact that there were long waiting lists post-COVID. It was 2021. The individual consultant was asked, as were a lot of consultants post-COVID, to get involved in doing NTPF clinics to try and address the waiting lists. As I say, the individual was paid, did this above their contractual hours and was paid through HC.
I accept all that, but my concern here is if it didn't meet your threshold to report to An Garda Síochána and it did meet the HSE's threshold to report to An Garda Síochána, have we got a scenario here that you're both operating off different thresholds?
I suppose we have to await the outcome of the Gardaí.
I just think it's really, really bizarre that the HSE, out of an abundance of caution, have done the right thing, referred this to the Gardaí to make a determination, but the CHI can take it upon themselves to do the Gardaí's job for them and decide that it doesn't meet a threshold for investigation. And the fact that even after this has come out and blown up publicly that you've still held this view, I don't think that attests to this new culture of transparency that's outlined on multiple occasions in your opening statement here today. In fact, I think it's quite the opposite. But if you can give me a yes or no answer on this, do you still believe that the potential of misuse of public funds doesn't merit a Garda investigation? And just a yes or no on that.
I don't think there was misuse of public funds, so the answer would have to be that.
Okay. I look at, as I've said, in all these instances, it seems, and I can't say for certain, but it seems the HSE are doing the right thing here. They've wanted this report published. They wanted the misuse of public funds investigated by the Gardaí, and it seems that the CHI is not on board with that. You've opposed publishing the report in full, and today it's still not published, just a sanitised, editorialised, if that's the word you want to use, version of it. The head of the HSE is not resiling from his view that an anonymised version of this report could and should have been published. So here we have a situation that the head of the HSE has a fundamental difference with you guys on this. You've chose not to publish it. Is that still your view today, that it shouldn't be published?
We actually redacted a version of the report to see would it make sense to our stakeholders. It didn't. We wanted to go further by actually saying what we did on receipt of the report. The 34 recommendations, bar 2, have been closed and can only be closed when we move to the new Children's Hospital. So we were trying to, I suppose, provide further assurance than just a blacked out, redacted report. It is, or was primarily a HR report. The 45 staff who were interviewed and participated in it did that on the basis of confidentiality, so they could be open and transparent and give the information that we needed to find. So I suppose from that perspective, we still stand by that decision.
Okay. And the next couple of questions, if we can just keep them to be yes or no or as near to that as possible. There are several examples in this report of substandard care. In any of these instances were the parents made aware at the time?
No, because they did not meet the threshold. I'll hand over to Ms Kelly, who can give you a very good description.
No, that's fair enough. I've actually heard your response on a previous committee, so I am aware. When the Dixon report was completed nearly a decade ago, it identified a cohort of children with spina bifida who had fallen through cracks and who were receiving suboptimal care. If we fast forward 5 years, when this review was done, CHI couldn't even tell the reviewer how many children were affected. Their care plans were never changed, and this review found that they were still receiving suboptimal care. And I think we're talking something like families of 38 orphaned children here in this particular incident. Were their parents notified?
I'll hand over to Ms Kelly.
And if we can keep it 10 seconds, please.
I know we have 254 children that currently attend our spina bifida service currently within CHI, and would be assured that the teams that are looking after those children are of high value.
That's not what I'm asking. Were the parents notified?
So the parents of which patients?
The ones identified in the Dixon report and the ones identified 5 years later when this report was done. So these are the orphaned children.
There's two. So and it's an awful term. The children that were identified in that report, to my knowledge, so they were children that didn't have a specific a specialist looking after them, that didn't have us insert at that time in CHI. Those children now all do have a specialist looking after them. As to any historical issues that those children still have, I'm not aware at this stage.
So again, there's no culture change here. You know, if we hadn't learned lessons from 10 years ago to 5 years ago to as recently as weeks and months ago, it seems that there's still no culture change.
The children that are under care now, I can assure you, are getting the absolutely highest standards of care by a very committed and compassionate team of clinicians. And the multidisciplinary team, I can assure you of that.
Yeah, and previously when you were asked this question, Ms Nugent, you said that these families or parents or guardians didn't meet an open disclosure threshold.
For the unpublished report?
Yes.
Again, I will hand to Ms Kelly. She'll give you a very good answer on that, because we do want to explain it.
So there was 179 children that were seen through that initiative that we spoke of. Of those children had already been rating an average of 19 months, and that was post-COVID. So the initiative was introduced to see those children quickly. Of those children, 51 required to go on to have further additional treatment, and that treatment was all completed within 4 months. So by September 2022, all children had their treatment completed. So actually they were seen quicker.
You must be aware that spina bifida advocate groups and many of the parents of these children affected have been asking for this information. So it's not necessarily about open disclosure and you having to decide whether to reach out to them or whether they meet a threshold. They've reached out to you and they've got nothing. They've been absolutely stonewalled. And if I refer back to your opening statement again, Ms Nugent, you've said yourself, our intention is always to ascertain the facts and take steps to fix the issues, while at the same time telling parents and children what we are doing. And that's not the case. So we'd have to ask what's going on. You're talking about accountability. You've got multiple reports. You've the unpublished one, you've the digital one, which have identified a bunch of children with spina bifida receiving suboptimal care. And yet their parents know these reports exist and have contacted you, and they are being absolutely stonewalled.
So there was contact made with the families at the time of the Dixon report. There was a working group between the two entities to go through some of the recommendations. And I understand, and again, my colleague Ms Hartman can say there was engagement with families at that time.
I know we're out of time, sorry, Chair. Thank you.
Kenny.
Thanks very much, Chair, and welcome to everybody. First of all, I'll turn to the CHI consultant at the centre of the review. Were CHI, was the Chief Executive of CHI aware he was doing the weekend work?
Not specifically, that would have been by the operations team.
Did you know yourself?
No, I knew that they were seeking, that we had long waiting lists and that there was initiative by the operations team to...
But did you know this consultant in particular who couldn't carry out the out-of-hours work?
Well, I knew he was not doing on-call, but that doesn't mean that he obviously could do outpatient clinics and was doing outpatient clinics. Yes.
I don't understand that. Like, if he wasn't able to do on-call hours, why was he able to see, you know, twice the amount of patients he'd be able to see during the week?
Yeah. I think the issue is that the on-call is got to do with maybe being called at 4 o'clock in the morning and coming in to see really sick children. So that was advice that was given from occupational health, and we followed that through. But that doesn't mean that they're able to see and work and do an outpatient.
Did you bring it to the attention of the occupational health that he was also carrying out work at the weekends? So did you not question at the time, how could he carry out work at the weekends even though he actually can carry out?
I think what we did from occupational health is that we were advised that the only thing he couldn't do was on call, so everything else that he could do. And in relation to the numbers and the clinics were longer than our normal clinics because they had lots of room to themselves. And plus, the patients that were taken off the list were probably the less complex because they were at the end. So inevitably, they actually could be seen quickly. Plus, the original clinics were supposed to be off-site because of COVID and the restrictions that we have within our hospitals at the time, which meant that the patient that could be called didn't need to have X-ray, couldn't have phlebotomy, couldn't have actually labs, so it restricted the types of numbers we've done. So there are circumstances around here.
You will appreciate that I'm asking this question because €450,000 is spent on a locum doctor.
Yeah, and I think that was required.
That's public money, like.
I agree with you, but
And he was being paid by public money through the NTPF as well.
And we needed to have a safe service whereby we had an on-call consultant, and we had them across 3 sites. It was one of the issues that we were trying to address at the time, which is a significant burden to that
I don't know,
team.
did you ever hear the phrase running with the hound and hunting with the dog?
Well, I have heard of it, yes.
He seemed to be doing a bit of that, like.
Are you talking about the consultant or
Yeah.
the locum? I don't think so. I think, to be honest, I think at the time the operations team sought with the consultants across CHI as to do initiatives because of the numbers had increased significantly during COVID to do clinics. This matter actually did come up in 2021, and was addressed, you know, to ensure that we had good internal processes. The NTPF did audit us in 2021 and we were compliant to that.
I'll just move on to the board effectiveness because of the time. The internal report that was carried out, Ms Nugent, you said, you know, an anonymised report wouldn't make sense. Why?
Because you have to anonymise the text, the individuals' identities, the quotes from those individuals, because they would be identifiable. The service would be identifiable.
Give me an example of a quote that would have been identifiable.
If a trainee spoke about an experience, a specific episode, that would be identifiable to, you know, I suppose the health community is very small. And if they were talking about a colleague, that colleague would be very identifiable by the nature of the procedure they were doing. Or
so what's your belief on the HSE, on the Minister for Health, on the Taoiseach saying that this report should be published?
I respect their opinion. I suppose I do have to balance that with the legal advice.
While you respect their opinion, do you believe they're wrong?
I think I respect everyone's opinion. So I'm not saying whether they're right or wrong. I also have the balance of, number one, the legal advice we were given. Number two, to, I suppose, provide fair procedures for my staff and the confidentiality of the process, because I am trying to rebuild a positive culture, and having staff feeling they can speak openly and speak up is really important. So that is another
I'd just be questioning now the effectiveness of that external evaluation, considering that a number of people have stepped down from the board since. Would you not question that?
That would be a board matter, not for me to comment on.
Would you question it yourself, perhaps? The effectiveness of the external evaluation?
That would not be for me to comment on.
Has the board discussed that?
I'm sure they have. Board always have board-only time when they discuss
Have any members of the board brought that to your attention in conversation? You know, that external evaluation mightn't actually be fit for purpose, considering a number of people have stepped down from the board since?
No.
Nobody at all. I'm going to move on to the settlement of the former CEO, which is quite important and was brought up here previously. And the fact that, I suppose, I appreciate that you're in the room, and that's very important to realise. So what is the role itself? Like, what is your job? What are you doing right now?
Yeah, so the title is the Strategic Programme Director. The board determined that there were certain policy and strategic elements that needed to be progressed with everything else that we're trying to do in CHI with run hospital services, merge and actually work with the Development Board, obviously, with the New Children's Hospital. So, and given that the New Children's Hospital is near to being handed over to us, it was important that these strategic projects were actually implemented. So, for example, I'm working, given my experience actually in setting up the All-Ireland Congenital Heart Disease Network that was very successful, and last year set up also an All-Ireland complex pain.
So was this role specifically created just for you?
No, I think the board has determined, quite rightly, that there was a strategic projects that needed to be progressed.
When did they determine that?
That was actually in, I was offered this role in April of 24.
You were offered that role in April, so you stepped down in October 23, is that correct?
I had sick leave due to surgery for a period of time,
and then you took over in April 24. What's your understanding of when the board decided it needed this role? Was it discussed while you were CEO?
Pardon me, I didn't hear.
This role that you are currently in now, was that discussed previous to your stepping down?
The projects were definitely identifiable and
but was this role identified?
No, but the work was. There's no doubt, if you look at the strategic objectives for Children's Health Ireland from 2021 to 2025, it's very clear there are some big strategic priorities there. I will accept that we had 2 very abnormal years with COVID and the cyber attack, which impacted.
And just in relation to the role itself, do you find it difficult to be still on the senior management team, considering the amount of scandals that actually happened while you were CEO?
I think that, to be honest, I think the team are collegiate. I think that I'm very committed to the.
I don't doubt that.
And I do think that also we're very professional. I think that there's an awful lot of work to be done. There's a huge amount of work to be done to actually achieve what we need to achieve. And so
how much did how much did CHI pay for the legal costs incurred?
That was, well, I don't know who paid for it. I do know the cost, but I don't know who paid for it.
Does Mr. Fitzpatrick know?
I understand it was settled by the Chief State Solicitor's Office.
Do you know how much that was?
Yes.
What is it?
Including VAT, 123,000.
123,000 to the taxpayer?
Not, CHI did not bear the cost.
CHI did not bear the cost. Who bared the cost again, sorry?
Well, I understand it was settled by the Chief State Solicitor's Office.
Interesting. I suppose confidence in CHI, that's it's something that comes up quite regularly. It came up the last time you appeared before the Public Accounts Committee. After that Health Committee meeting that you had, the lack of satisfaction, I think, that I got from the cultural change at CHI. Like, can you just give 1 or 2 examples of how culture has changed in CHI?
Well, as I say,
since you've taken over.
Since I've taken over, I suppose, first of all, I suppose, I think as CEO, I have positively engaged and have received positive feedback in that we are engaging very proactively with our staff. So town halls are face-to-face in the sites. The online city halls, again, are very well attended to several hundred staff. I met with the Joint Medical Board last week, 128 consultants engaged with me.
Very good. That's a couple of them. Well done. So the out-of-date claims, this was brought up previously as well, the out-of-date claims to the insurers, €250,000 out-of-date claims in 2023, 183,686 in 2022. How much for 2024?
200,000.
200,000?
200,000. So
250 plus 200, 450, plus in and around 183,000.
Yeah.
In 3 years.
For 2023, the 250,000 represented 70 invoices, which were raised.
Where does the accountability lie here?
So in CHI, all of those invoices would have been raised in a timely manner, usually days following discharge. We can only, the insurer will only accept and pay them if they're part of a fully collated claim. So that involves getting the paperwork from all the
What's the required time frame?
For the hospitals, it's usually up to a year. For the participating other third parties, primarily the consultants, it can be up to 3 years.
Whose desk does this lie on now in terms of accountability?
Well, my own desk, in terms of trying to ensure that these claims get submitted, and
So are you taking the accountability issue here?
it's not within our gift to actually submit them all. We do need the third parties to engage with us, so we do engage.
Whose gift is it within?
Well, it's ours to drive it. To drive
Did you drive it?
Yes, and we're
Not good enough, I presume.
We're continuing to improve the practice in that regard. So then we're meeting weekly with the relevant participating third parties, and the submissions are improving.
I wish everyone the best in the role. Confidence is absolutely paramount here, and I hope the public get the confidence that they need. I'm quite doubtful about it, but I wish everyone the best in the role.
Thanks, Deputy Kenny. Deputy Gagan.
Thank you, Chair, and thanks to the witnesses for attending. Ms Nugent, you said in hindsight we should have engaged with the CNAG and the NTPF on these issues, and Ms Hardiman has confirmed that the report was not furnished to the HSE, and there's sort of loose language that was put in a letter to the Minister for Health in terms of the level of engagement with the HSE on the matters contained in the report. Should you have done more in hindsight in your engagement with the HSE as well, in your view?
Back in 2022?
Yes.
Yes, I do.
And in relation to the Garda referral, okay, you're familiar with what the threshold is for referral. I presume it's under the Criminal Justice Act 2011.
Yeah, we took advice.
And you're familiar with that, with the threshold. Again, so you've said we should have referred to the CNAG, we should have referred to the NTPF, we should have referred to the HSE. In your view, should they have referred to An Garda Síochána as well?
I think what should have happened in hindsight is that the unsubstantiated statements should have been investigated and validated as true or otherwise. On examination subsequently of the report in relation to the allegations made about the individual consultant regarding misappropriation of funds, etc., was not the case. So in that, in hindsight, I think these things, when a report is commissioned and a report is given, it needs to be looked at, interrogated, and unfortunately it did not happen on that occasion.
But just to be clear, I mean, it's the Garda's job to investigate matters. There's a report, and the threshold is exceptionally low. In your view, should it have been referred? You've been very clear in hindsight on the others. Should it have been referred to An Garda Síochána? All things being equal right now.
Not on the legal advice we've received, no.
I'm not talking about the legal advice. I'm talking about your opinion. It's not about legal advice. It's not about legal advice. It's factually on the reports, the information in front of you. You've been exceptionally clear. More should have been done in every other entity. What about An Garda Síochána? What's your own view?
I don't think the individual did anything wrong in that regard.
That's not the question. Should the report have been referred to An Garda Síochána or not? Yes or no?
I think the statement made that if it was substantiated that this person had
That's not my question.
misused.
Yes or no? It's a yes or no question. It really is yes or no. Should it have been referred or not? You've been very clear. No, it shouldn't have been referred. Okay. Ms Hardiman, it's a bit of a whitewash in terms of the approach that was adopted under your reign in respect of all of these issues. The current CEO has made clear that a whole host of entities were not engaged with appropriately, and leaving aside the Garda Síochána issue. First of all, why did you commission this report in the first instance?
Thank you, Deputy. I think that is an important question. When Children's Health Ireland was established in 2019, it was clear through 19 and 20, less so in 20 obviously because of COVID, that there were issues with this particular service, and it seemed to be different issues were coming up through different members of the executive and different things that happened. Most of them seemed to be around operational matters. So in 2021, we decided to actually assign an operations person to this service to try and address
Okay, but factually you were nervous about something going on in the hospital, you got a whiff of something and you proceeded with an examination. Is that right? Just be clear, because I only have a limited amount of time.
We did know, and we put somebody in, and she came back and she said, there is more to this, you need to open this up, and there's a lot of
So the report was concluded, and according to the information you've supplied to us today, it was presented to an ad hoc meeting of the board.
That's
Right, so this was, instead of the ordinary meetings of the board,
It was a
the board
single
was
item.
specially convened just for examining the full report, or what did the board do?
The report,
Because there's some reference to a report of a report. Was it the full report that the board examined on that date?
The board, that was the report that the board received and the recommendations by the.
And did you have a view, or did a board have a view, as to what level of engagement from that moment on should have taken place with the NTPF, the CNAG, the HSE on Garda Síochána?
So the issue of the clinics happened in 2020 and those extensive engagements with the NTPF by the ops team at the time.
No, that's not the question. No, my question is really clear. So on those 4 entities, did you have a discussion at the board? Did you have a discussion at the board? Should we tell the HSE more about this? Should we tell the NTPF more about this? Should we discuss this with the CNAG? And should there be a Garda referral?
Yeah, no, at the board, yes, there was the issue of engagement with the NTPF. And regretfully, that didn't happen. That was raised at board. The others were not actually raised at board.
Weren't even discussed or deliberated?
I think the issues in the report that the biggest concerns were about the culture, HR, and the team dynamics issues, because those were, as we understand, there's lots of research to demonstrate that good team dynamics is important for patient safety. There was a particular patient safety risk issue that was a single point of failure. That was the highest risk issue. So from the recommendations, they were rated as to what's the immediate that needs to happen. There was extensive and ongoing engagement with the NTPF in 2021 around these clinics, and this matter should have come up then, and it didn't, and I regret that. But I think the focus was on the patient safety and risk issues. They took the priority in relation to.
You then implied in your testimony today that it was sort of an obligation of the interim CEO to fully brief Ms Nugent, the new CEO, in respect of this internal report that she only became aware about because of media. Was the interim CEO fully aware of this report and the contents of this report? And had you discussed this with her?
No, because I think I went...
So why did you imply that it was the interim CEO's responsibility to brief Ms Nugent then?
I'm being clear about it here, because I went out on sick leave and was expecting to return, so I didn't do a full... There was a handover. She was a deputy CEO at the time, so she understood a lot of the issues. So in relation to CEO handover, that didn't happen because of the
So how could Ms Nugent possibly have known in relation to this issue, other than you, or who could have informed her in relation to these issues?
I think that, definitely that because the issues, Deputy, were addressed, because the recommendations out of that have actually been addressed, and because the risk issues in particular and the patient safety issues had been addressed. And this is a better team. These services are safer because of the interventions. So I suppose there's a lot of issues happening.
But right now, and this is with the benefit of hindsight, but that's what we're here to do. Clearly your intentions were good in terms of trying to identify challenges within the culture and this individual as well. But the outworkings of the report produced a whole other host of stuff that effectively the hospital, the CHI, just ignored. They didn't carry out any further due diligence in relation to the issues of the NTPF. And it's only now, all these years later, because this NTPF issue is published, we're now seeing that this is unravelling into other hospitals, Beaumont Hospital, Naas Hospital, 2 unidentified hospitals. Like, this is where transparency matters. And I have to say, I'm unbelievably frustrated with the responses in relation to open disclosure, that there was no scientific evidence to tell these parents that if I'm a parent of 3 children, if my child was entitled to have been treated in a hospital in accordance with the waiting list and they weren't treated in that time, you should bloody well tell them. And why haven't you told the parents of these children that they didn't get the operations in the time that they should have because there was a rogue individual involved in using waiting list initiatives in a way that it shouldn't have been done?
Yeah, well, okay, there's several questions to unpack there. For starters, if going back to the NTPF, I do regret that we didn't actually explicitly raise this issue. But since then, and because we raised it up through the board, the Audit and Risk Committee actually did put on auditing of our waiting list procedures on its audit plan. That was part of what was done in 23, that started in 23 and was completed in 24. So the board did actually respond to that and that demonstrate that we have a robust process.
Well, why not tell the parents of these children that didn't get their treatments when they should have?
Well, I think...
Why not just do that?
No, I think that the issue of open disclosure is a separate matter.
No, but I'm just asking factually right here. Why don't you just do that? Tell the parents that they didn't get the treatment that they could have got because of governance issues in your hospital. What is the problem with just telling parents this?
I'm trying to answer your questions,
Yeah.
Deputy Gagan.
But the children that were treated through the NTPF clinic that was established, that was done as extra core activity for that consultant, were children that would otherwise not have been treated, were on a long waiting list within the public system. So actually,
Kids skipped the list. We know this. This is what happened. Children, this is what the report found. That, I mean, am I wrong on this? Children were treated ahead of other children that should have been treated.
So the lower complexity children that were seen in that clinic were treated in a time appropriate, in an appropriate
There were
time.
children that were bumped up a list, or that were treated in a quicker way than they should have been treated. That's what the report says. Am I not right in that?
This is an additional work at the weekend, so it didn't affect your core activity.
It's not
during
about the effect.
weekday.
It's about the
Yeah, but
idea
about
of
the effects for the
transparency.
the
No, but it's
children.
but it's about parents knowing this because it's come out there, and now they want clarity. And I don't think that's unreasonable. Finally, in the report, Ms. Nugent, that you supplied to us in questions, you mentioned that you've had engagement with the Medical Council. What does that mean? Have you referred the individual, the subject of this investigation, to the Medical Council?
So I have been, I've had 2 meetings with the Medical Council and this matter is now closed.
What does that mean?
That there's no further action being taken.
And should you have referred this to the Medical Council, Ms. Hardiman, the individual? And did that come up in any discussions at the time with the board at the ad hoc meeting?
No, Deputy.
How? How is this possible? How is it possible that this individual, the subject of this review, that we keep getting told was a HR review, not to do with macro issues can't be shared, and at the heart of it, an individual, which is a HR issue, and a decision was taken not to refer the individual to the Medical Council?
The matters actually out of this report went through the appropriate HR processes, and I can't get into them anymore because of the confidential nature of that.
The new
And they
CEO
were-
decided 3 years later, yes, this is an issue that should be referred to the Medical Council. 3 years later.
If I may, Ms Nugent, I think want to talk to the Medical Council in relation to this. I'll hand back to you.
But I'm right. I mean, that's why you referred it.
I wanted to close it out.
If we can be brief, do you wish to make a comment?
I wanted to close out that matter.
Thanks.
Okay, thanks, Deputy Gagan. Deputy Farley.
Thank you, Chair. Thank you, everybody, for being here once again. Mr Gallagher, in your opening statement, you say the NTPF has strong financial oversight procedures and processes in place to administer insourcing funds. I assume by including it in your opening statement, you fully stand over what that says.
I can't stand over it.
Okay, that's okay. That's okay. Yes, that's yes or no. Can I ask, when was the last time the NTPF audited CHI?
We don't audit CHI. That's not our responsibility.
Sorry, I just might interject there. In relation to the waiting list management, the last time the NTPF audited CHI was 2024, and that was CHI Connolly, where they do the central referral system.
But in the entirety in terms of funds allocated to CHI as an institution?
No, just in relation to the waiting list management, we have no legal basis to go in and audit any hospitals from an acute hospitals from a financial perspective. That's correct.
Even when there's insourcing taking place?
Correct.
So how can we have strong financial oversight procedures if we're not checking the financial insourcing agreements?
So I might just talk you through the process, Deputy, in relation to how
Briefly,
we manage
please,
insourcing.
Ms. Brady.
Outsourcing is very different. So when an initiative comes in from an acute hospital, we review it, the commissioning team review it, and we make sure that there is patients on the waiting list, the longest waiters that have been requested to be seen. And we always check that our MOU was signed, and in relation to the process of our MOU, that this is going to be done outside of core activity, that they are going to pay the consultant and any ancillary staff that may be involved in the initiative overtime rates as per our MOU. And then we agree in principle. We only pay.
I understand that, Ms. Ray. I understand that. In terms of strong oversight, what's happening in Naas Hospital, please?
Well, I mentioned earlier on to Deputy Boland that I was doing a national assurance review, and in light of that, as to what the compliance was like in relation to our MOU. And NACE made a full disclosure that when we agree a price per patient, Deputy, that covers the consultant pay, covers the clerical staff pay, the nursing pay, the whole lot. We do not pay consultants directly, only the hospitals, and then they pay out the individual staff so in NACE Hospital they had been paying the consultant per patient, which is against the rules of the MOU and indeed the national financial regulations.
And how can that happen? Within a context of strong oversight, how can that be allowed to happen?
So, as I said, Deputy, we pay the hospital, and the hospital then pay the individual staff. We never
So it's
pay
the hospital's fault?
No, I'm not saying that. It was a decision that they made. We stood by the agreement that we made with Naas General Hospital in relation to the initiative, €200 per patient. That will cover everything that you need in relation to that patient. Unfortunately, Naas General Hospital, it would appear that they paid the consultant per patient, which is not... we would have no oversight of that, of how the payments are made at the hospitals.
And what are the consequences for potentially breaking an MOU like that? Do they lose funding?
To be fair to Naas General Hospital, they contacted me immediately and they were very concerned about it, and I had discussions with them. But the manager of Naas General Hospital stepped in immediately and said, I think I need to review what's going on here and I'm going to stop all insourcing, and I agreed with them in that regard. It was escalated then to the HSE, and Mr Gloucester, as he disclosed yesterday, has sent in the internal auditors to review that situation.
And to the best of your opinion, of your kind of knowledge at this point, until close of business tomorrow, you're not aware of anything other than what's been reported already in terms of the 3. You don't believe there's any other incidents?
Nothing else has been disclosed to me, Deputy, apart from the 2 hospitals that we are seeking further clarification on, and I expect to get those by close of business tomorrow when we compile the report then and send it to the Department of Health.
Okay. Ms Hardiman, thank you for appearing here today. Really appreciate you being here alongside your colleagues. Can I ask the representatives from CHI, was anyone from the board invited to attend this morning?
Yes, the former board chair. Sorry. Yes, the former board chair was invited, Dr. Jim Brown. He sent his apologies. Unfortunately, he does have a prior commitment, but he has asked me to say that he would be happy to attend in the future if the committee so wished.
Anybody else, current board members? Was that a specific invitation?
No other invitation was received in that regard.
Ms Hardiman, did you, if you don't mind me asking, in the process of the last couple of years, did you request for this role to be developed when you became aware that your role as CEO wasn't going to be extended?
No, I suppose what I'm very aware of is the strategic objectives that the board actually had and was working towards.
But
that.
you mentioned this earlier, but you were managing those in your role as CEO at the time.
I think that we were identifying there was an awful lot happening, and the priorities were taking place was obviously services and issues and post-COVID and all of those things.
Were you consulted on the business case?
Pardon me?
Were you consulted on preparing the business case?
No.
At all?
That was, no.
The job description, nothing like that?
There was a mediated process to in actually saying, in getting to agreement on what the role is, and I think the board did determine the particular strategic elements that actually this role could focus on. It was already work that was required to do, and it determined that assigning somebody senior to it would actually bring value to actually progress those, as well as everything else that we're doing within CHI.
I understand that.
There is a lot of huge amount of work required.
What the board, in terms of suggesting that and acknowledging what needed to be done, did that come before or after the board unanimously supported and requested the Minister for Health to extend your role for a further 5 years?
No, the board in October of 23 sought to extend the role of the CEO.
And when the Minister said no and they went back and sought that again?
Then, into 2024.
2024, and then the business case gets put forward to the department.
I wasn't part of that, but it must have been in that period because it concluded by April.
And then was there a recruitment process as part of that role?
No, this is an employment law matter. There's a contract of indefinite duration, and automatically, given that I had 2 5-year fixed-term consecutive contracts.
Okay. There's a bit of there was merit to the role, but also it appears there was an entitlement to the role as well. Then is that?
The Fixed Term Workers Act is very clear that there's automatically a contract of indefinite duration after 2 5-year fixed-term contracts have been awarded.
I'm curious as to your thoughts, Ms. Brady, Mr. Gallagher, in terms of potential conflict of interest with regards to the reporting this week that there are members currently working in the public sector that are directors of private companies being paid to do essentially the job twice. And a very simple approach would be, why would I work to reduce a public waiting list when I'm financially incentivised to not do so?
Thanks, Deputy. Mr Glasser mentioned that yesterday, and that's part of the national review that he did, and that's in relation to third-party providers. The NTPF do not engage in any third-party providers. We only engage with acute hospitals.
At all?
At all.
Ms Hardiman, I want to emphasise my thanks for you coming back a second time. I think it's really beneficial for us to have this opportunity to speak once again. I'm going to finish by, I suppose, giving you the opportunity to recap where things are at now in terms of confidence in the institution, confidence in the transition, confidence in the future of CHI. I would like to put on record the many people who have communicated with me their abject lack of confidence in the institution. That is not the workers, that is not the experience for children who are able to access the services, but for what the future looks like in a transition period of such importance. I just want to give you the floor for the remaining time that I have to share what the future might look like for CHI under your leadership. Apologies, Ms Nugent, my fault.
Just, no problem at all. And thank you. I fully recognise that we have to rebuild both our reputation and the trust that we need, the public, our patients and our staff. And the future is bright. We have an amazing building, but a building doesn't deliver care, the people do. So the most important thing is to I suppose, ensure that we attract and retain and develop the best staff that we can to provide the best care that we can. And that's just not what we're doing now, it's what we can do in the future. There's the opportunity to bring together all these fantastic staff from multiple sites into one location and 2 satellite centres. That will enable us to repatriate some things that are sent abroad from a diagnostic point of view or care point of view. That's really important because I think having to travel when you have a sick child, even if it's from Donegal or Cork, is stressful, let alone to get on a plane or a boat. So we certainly wanted to expand and develop our services. We want to have research and innovation at the centre of what we do because medicine and healthcare continues to evolve at a rapid pace, and I want to make sure that our staff are aware of what we can offer our families in a safe way and in a quality-driven way to drive outcomes. And I think we're focusing on that more. Is that we are learning how we can do better. Our parents, our children, and young people are part of that process, absolutely, as well as everyone around this table. But as I said, I could talk about the transformation programme, but I think we're running out of time. There's an extensive transformation programme led by my colleague, Ms Julia Lewis, which ensures that staff are ready. This is a unique and transformational opportunity for the state and for us in CHI. We're merging 3 entities with 3 cultures, but with shared values. We are going into an amazing building. We'll be fully digital. That is challenging, but we're up for that challenge. And equally speaking, we're being well prepared through our OLUS education and training programme. There's a tried and tested methodology, for example, called a Go Live Readiness Assessment. I can hand over to Julia, but we've run out of time.
Unfortunately, we have Ms Nugent, and I know you could talk all day about it, and I appreciate that, but unfortunately the clock is against us, and I now propose that we take a short break, so the meeting is suspended until about 12:15. Thank you. I'll call our next speaker, who is Deputy Dolan.
So look, today I want you to clearly set out what has actually changed since you were last here. I'm conscious it was just over a month ago that you were here. What concrete improvements have been delivered, and where can we now show that the issues raised here have been addressed or are in the process of being addressed? We need evidence of progress. We don't need the same problems. The families and children depending on your services deserve nothing less. So, CEO Lucy, thank you for being here. Could you please outline what you have done in the past month since you were last here?
Thank you very much, Deputy. So in relation to our actual governance structures, when I took up my first role initially, the clinical director role also had site responsibility and they weren't with their actual team. We have rearranged that and we've also taken the site responsibility off the clinical directors. No disrespect to my colleagues, they are fantastic, but they wouldn't necessarily have the skill set, and also they have enough to do in the clinical director role. So they have a bit more time now to actually engage with our clinical colleagues in that regard. We have rolling out our clinical specialty leads programme so that each specialty has a lead. And this is moving away from maybe the traditional kind of advocacy role for resources, etc., to actually managerial and leadership roles. So we've revised that job description and our colleagues are being interviewed for that process. So again, it's an open and transparent process as to how someone takes on that role. In relation to the executive management structure, I've advised of the posts that I have filled. This is going to give stability to our executive management team. We've also streamlined how we do our business and those new processes.
Just on that, how you do your business. How do you plan to shift the culture and change the culture within CHI? Because that seems to be the #1 issue that's pervasive across all reports, across all media, across the presentation stuff here, is that the culture here is toxic. So how are you going to change the culture?
Well, firstly, I would have to say the culture is largely positive and there are pockets of culture that are not working. It is not across the entire organisation, and I would be doing a disservice to my colleagues if I said otherwise. So there are a number of cultural programmes underway. Some of my colleagues are actually down in Dr. Stevens's as we speak, and we will be joining them afterwards. We're doing a full-day workshop with the HSE about the national cultural programme they're running out, so we've put our hands up to engage in that. In relation then, I suppose, staff need to, #1, get to know me. I'm new, so I've made it my business to, as I said, have the engagement sessions I was talking about. But we also need to listen to the people who use our services. That's important. We're lucky that we do have the Youth Advisory Council. They're made up of young people who have either are current patients or immediate past patients of CHI.
Okay, I really appreciate that, and I appreciate that you're engaging with the HSE to try and improve the culture, because that is a serious concern. One question I raised the last time I was here, and I did ask for you to review it and look at it, was you said that the consultant who had caused a lot of this havoc was out on paid leave, and it was voluntary. And I thought that was wrong, that that person was still being paid and that it was a voluntary leave. What's the status of that individual, and are they still being paid to this date?
I'm going to hand over to my colleague in relation to that.
Yes, I understand they are on administrative leave being paid.
Just clarify, administrative leave versus voluntary leave, is there a difference?
There was, I don't know the technical difference, but then
They go by their choice, or were they told to go?
That's it. So I suppose just if I may ask, that there is a HR process ongoing, and I'm very cognizant of not saying anything to jeopardise that process.
Okay. The next question shouldn't jeopardise that process. Do you know how much that person is still being paid monthly, even though they're not there?
I don't, but also I wouldn't be in a position to comment on anyone individually.
Okay.
They'd be paid in accordance with the approved consolidated pay scales.
Okay, so they're still on their full pay scale as they would have been as if they were showing up at work, but they're not. Okay, and there's a HR process ongoing.
There is a HR process ongoing.
And when you said that it was completed with the medical council, is that the same individual we're talking about?
No, that's a different individual.
Separate. Okay, that's okay. Thank you, and I appreciate that. Ms. Hardiman, I just, if possible, could you just provide me with an outline of how you came to be appointed in the strategic director role?
I said this is an employment law matter. Sorry, am I back to you here?
No, you're okay.
Employment law matter. So as I said, it's the Board of CHI actually appoints the CEO, and in accordance with the Act, with the agreement of the approval of the Minister for Health. I had 2 fixed-term contracts that was part of the hospital group structure that was in the HSE before the board was established in 19. I transferred to the CHI as part of that legislation. The board then, given that because asked and recommended that I be extended for another 3rd term, As I outlined, Deputy, the government policy position on this is that non-commercial state board CEOs are appointed for a 5-year term with two consecutive periods.
Can I just ask Ms Hardiman for clarity?
Yep.
When you realised that the Minister was not going to approve your reappointment as CEO, did you take legal action at that point to secure your future in the organisation?
Yeah, I think the issue was that we needed to reach an agreement.
Well, did you take legal action?
And yes, I did.
Okay.
Actually, and it went into a mediation process.
Why did you feel the need to take legal action?
I think
Had you not served your time in the 10-year period you were there?
No, I was. It was the fact that it was a contract of indefinite duration was just to follow through on that legal element of it.
And so then you were, I guess, selected for this role of strategic director on the exact same pay as the CEO. I mean, what strategic gaps existed that justified the creation of that position?
So going back to it, said it's an employment law matter, so the last contract automatically becomes a contract of indefinite duration. That's the law. In relation to...
And that legal issue cost the state 120,000.
The agreement to actually conclude the thing was what the mediation is, yes.
But the Chief State Solicitor had to pay 120,000 to rectify the legal issue that was brought forward by you, which led to the mediation, which ultimately led to you being put into a role.
To get an agreement to the mediation process, that's where
the Chief State Solicitor's officer paid 120,000 for that.
Well, I understand that's the fees that I didn't know.
Okay.
And the work was always there, Deputy, just to be clear, that there's very clear strategic objectives that were outlined.
So who was in that role before you?
No, it wasn't, and the work maybe didn't get the focus that it was actually getting on because.
But this was a new role.
This was work that needed to be done.
Was it a new role?
Well, the role, yes.
Yes.
The board determined that I'd be assigned to this. The board determined that.
And do you think the board were influenced by the fact that they had been dealing with you for the previous 10 years?
I can't comment for the board.
And how, like, you know, the last time the CEO, Ms. Nugent, was here, I asked her, did she feel if you had the same responsibility now as you did when you were CEO? And obviously, as a strategic director, you don't have responsibility for the thousands of people, or you don't have responsibility for the over €600 million budget. So can I just ask, do you feel your wage is justified?
I think it's an employment law matter, Deputy. I mean, the law is the law, and the employer and the employee have to follow through on that. I am totally committed to the projects that are doing. They're very important. It's good that they're getting this emphasis. I mean, for us to leverage what's going to be with this new children's hospital, we do need to move on some big strategic projects. So
okay, look, I really appreciate you coming in, and I know it's an employment law matter, but it is really hard for the public to accept that somebody who was in the CEO for 10 years, had finished up their duty, has now come back into a strategic director role. It doesn't aid the image of CHI or the culture that we have an issue with. Speaking of CHI, and I guess something that's of major concern for me, and I really need reassurance around this, is that transition team. When that hospital, please God, it gets handed over September 30th from BAM to the CHI transitioning team and the MPD-HB, is the transition team ready to rock?
Absolutely. And I would like to give my colleague a chance to tell you some of the fantastic work they're doing.
Yeah, I'd appreciate that.
Lewis.
We are absolutely ready to go. We were, as you know, we're expecting the building on the 30th of June of this year. So we would have been ready to go on the 1st of July, which was this week. We have all of our planning done in terms of the operational commissioning period, which will take 9 months. That will roughly put in over 60,000 major pieces of equipment. We will then have to integrate with the electronic healthcare record, and then we will have to train all of the staff.
Can I just ask one question, Julia?
Yes.
What are the biggest issues facing the transition team now before handing over the keys, and how do you plan to resolve those before you get the keys?
Our biggest issue and the first issue on our risk register is the fact that we have no defined substantial completion date. That is singly the biggest issue for CHI, because while we have all of our plans in place, we cannot attach a date to it to actually make them run.
Okay, thank you. Thanks, Chair.
Thanks, Deputy Dolan. Our next speaker is Deputy Ardagh.
And thank you for coming in again, Ms Nugent, and thank you, Ms Hardiman, for coming in to the committee. Obviously, I know you're a previous CEO and you've done a lot of work, especially in terms of getting the Children's Hospital to where it is, and that will be, I'm sure, a very proud day for you at the opening of the hospital, and I think that work has to be acknowledged. I would like to know, just in relation to, I don't know if there's someone from the Department of Health here who can answer this, but in relation to the HICWA report on the use of springs, there's no one who can answer how much that cost. Obviously, I think last time we had a Department of Health official here. There was no contribution from the CHI to that report.
Well, the HICWA as a regulatory body did the report.
Yeah, I know that. So
Yeah.
you have nothing. You didn't contribute to payment of that report.
Pardon?
On the last occasion, we had a Department of Health official, so they were able to answer that. So I don't think you can answer that question for me. Just in relation to Surgeon A referenced in that report, is that the same? That's the same surgeon we discussed previously, who's on administrative leave. That's fine, and they are on paid administrative leave.
That's my colleague answer that.
And when did the paid administrative leave start?
I don't have those details.
October 23.
October 23.
October 2023. Okay, thanks. And then just in relation to obviously yesterday we had evidence from Bernard Gloucester in relation to Naas General Hospital. He wasn't able to give us specifics. Ms Brady, you were able to give us a bit more specifics in relation to Naas Hospital. There is 2 other hospitals have been mentioned. Are you able to give us any more specifics in relation to irregularities in relation to the National Treatment Purchase Fund at those hospitals?
Thanks, Deputy. Unfortunately, no, not today, but my closing date for receiving further clarification is tomorrow evening, and then I will put the report together.
Would you be able to furnish the committee with an answer to my question, perhaps the day after tomorrow? So we might have it at our next meeting.
Yes, as soon as I get the further clarifications that I'm looking for, it is my intention then to speak to Mr Gloucester in that regard.
And I suppose one of the findings, or one of the allegations was that some of the activity across the hospitals was in relation to medical care conducted within normal working hours. Is that one of the themes that you're seeing across the board, or was that a sort of an irregularity when it came to Beaumont Hospital?
It was an irregularity just specific to Beaumont Hospital.
And have you had any? It's an isolated incident, and you haven't come across that again since?
No, because as I mentioned earlier on, Deputy, I did a national insurance review, so I haven't come across that again. No.
Okay. And just in relation to, I think Ms Brady, it may have been you, but in relation to NTPF payments to Knightsbridge Hospital, you said that was one of your major benefactors.
That's Kingsbridge in Belfast.
Sorry.
Yeah, no, that's fine. Yeah, from a private hospital perspective, yes.
Okay, and how much annually would that group get?
I might just ask Mr Flood there has the details there for you, Deputy.
So last year, in terms of Kingsbridge, and these are payments, there was 21.9 million paid. That was last year.
Okay, thank you very much. If I could just go on to the NTPF funding of and support for fair deal schemes. I know that from the Controller and Auditor General's report that you have responsibility when it comes to negotiating the prices with various nursing homes when it comes to fair deal. So I want to just know, what checks does the NTPF undertake when setting the price paid to an individual nursing home as part of the fair deal scheme?
Thanks, Deputy. Mr Flood is the Director over the fair deal scheme, so he might take those questions there.
Yes, so the process is not a procurement process, Deputy. It's a negotiation process. So when we engage with the nursing home, we send out a renewal pack. They fill in all their operational financial data. We would also get their financial statements that have been audited or signed off by an accountant. So we would carry out our own financial analysis, and that's all part of the. And we do it under 4 criteria. And one of those is the costs reasonably incurred and value for money to the state. And then we make an offer, and it's a decision then for the nursing home whether to accept or not the offer. So we do a detailed financial analysis of each.
Okay, and does the NTPF carry out checks after the agreement is reached to ensure that the prices are adhered to? into the future?
We don't, because we don't actually make the payments to the nursing home. We notify the HSE of what the prices are, and the HSE makes the payments to the private nursing homes.
Okay, so if there is overcharging, that doesn't come back onto your desk, is that what you're saying?
What do you mean by overcharging?
If the nursing home increases the fees subsequently to your negotiation, do you revisit that?
As I said, it's a negotiation process. We agree a maximum price, and they would bill. We will notify that price, and it's up on the HSE website. All the rates for all the private and voluntary nursing homes. So once that's agreed, it's published. They will invoice the HSE for those fair deal residents, and they're paid by the HSE.
And what if a nursing home charges over the maximum allowable price? And has this happened ever?
They can't. They can only charge the maximum price under legislation. They can only, and we notify that maximum price to the HSE, so they can't do that.
Okay. And do you have a role in relation to assessing that the appropriate level of care is being given in a nursing home?
No, we don't. Our remit is very specific. It's to agree the maximum price. We're not a regulatory body. That role is for HIQA.
Okay, so if it's the case that you hear, for instance, I know a lot of us watched it, we watched programmes recently on prime time. If you hear that, in the course of your working day, that a nursing home isn't providing adequate levels of care and they receive substantial funding from the NTPF, you have no role in withholding funding?
We can't, because we don't actually make the payments.
Do you have any monitoring or oversight role at all?
Again, that's a regulatory role, and that's a role for HIQA. That's not our remit.
Okay, thanks very much. I just want to say, I suppose, and just in relation to CHI generally, like we all know that all sort of governance irregularities and clinical discrepancies, and as my colleague pointed out, it's the family and the child who's at the centre of it. And we're here today and we're trying to disclose facts, we're not trying to prosecute, but it's really important that the families remain, our sole motivator to ensure that the children get the best care possible, the taxpayer doesn't overpay, and that staff working in CHI and other hospitals are working in an environment that's transparent, that's well run, that's fair to them, and I suppose that has to be your core mission for you and your team, Ms. Nugent. And obviously we're going to see a move now to the new hospital, and it's a really big project. It's one of the biggest projects, and it's a huge amount of work that's on you and your team. And the public want to ensure there's transparency. As politicians, we want to see transparency. And ideally, we won't be asking you in again because of something we read in the paper. And we don't like working on a basis of being, reactive. We like to sort of have a work programme. So, it's unfortunate that we had to ask you in again, but we're very happy that you have cooperated with us and have come in again. But I suppose just to make the point that it's the children, the families who have to be at the centre of everything we do, and obviously at the centre of everything you do. If you want to make a comment at all, be very grateful.
I would totally agree with everything you say in regards to, and the reason why our staff get up out of bed every day and come in is because they are committed to providing excellent care that is patient-centred. We want to make sure, as I said before, that we are transparent, engaging. In 2023, a family advisory network was established with families who attend CHI. We are intending to expand that programme. As I said earlier, our Youth Advisory Council are fantastic. That having the young people's voice is really important, because sometimes people think just because of age, we're all guilty of it, that they don't have an opinion. They have a really important voice. That's been reflected in the design of the new Children's Hospital, but I would totally agree. And people have to trust that when they are handing over their child to us, that they will receive the best care as if they were our own children. So I 100% agree with you. And every day our staff come into work to do a good job. We have failed on occasion. We're going to learn from that, and we're going to ensure that It's a risky business, healthcare. Can I say it will never, ever happen again? I'd love to say 100% something will never happen again. But unfortunately, because of the nature of our business, that sometimes things go wrong. But what I can guarantee is that we'll learn from it, and hopefully that thing won't go wrong again. It might be something else. But we're a learning organisation, and we are very cognizant of the privilege that we hold for the young people and their families.
Thanks, Deputy. Our next speaker is yourself, Deputy Neville, sorry.
Sorry for leaving you hanging. Thanks very much. Look, thanks very much for the organisations coming in today. Quite complex issues. And I suppose, look, there's a lot of learning. I suppose, but I might just jump around from people to people, if you don't mind. Ms. Eilish Hardiman, can you just establish just the timelines when you were CHO, when you went on sick leave, when there was an interim CEO, and when the new CEO came in? Just exactly.
Okay, so I've been CEO since 2013 and renewed in 2018, October of both years.
Yeah.
Pardon me. So in October of 23, I had planned medical leave for some surgery.
Was that just, can I clarify, you were finishing up though on the October 23 as well?
Correct.
Were you on sick leave when you finished up, or did you go on
Correct.
sick leave after?
No, I took sick leave, it was arranged the week beforehand.
So you went on sick leave a week before you were to finish up your 5 years?
Correct.
Okay.
There was a deputy CEO who acted up and during that period of sick leave.
How long did that sick leave last?
Until January
2 months?
24.
2 months?
Yeah, about that, I think 10 weeks.
10 weeks,
Yeah.
perfect.
Yeah.
And there was an interim CEO, yeah?
There was an acting CEO.
Yeah.
And then as the board had received the communication from the minister to say that the government policy has been implemented, that the CEO cannot, should only do 2 terms. So then we went into a mediation to actually...
When was that?
That would have been February, March, April.
So you'd come back and you're
No, I wasn't back. I wasn't
so you're
back.
10 weeks, but your sick leave, were you on sick leave or sick leave? Because you said your sick leave was up in January.
To January. No, then it was administrative leave while this was going on.
So you
And-
went on sick leave, then you went on administrative leave?
Correct.
Okay.
Correct. And the interim CEO then was put in place,
Yeah.
which was by the board.
Yeah.
And I returned then in May 24.
May 24?
Yes, that's correct.
And then, Lucy,
And the interim CEO was there,
Yeah.
in place, and
I took up my position on the 20th of January of this year.
25, so the deputy was there for a year? Pretty much. Calendar, it's 14 months.
correct. I think, yeah, she...
Just want to be clarified. Okay. And is it, so just from what you're saying, 5 years, so it's essentially what you're saying, what the legal situation was, because you've been there 10 years,
Yeah,
essentially in a previous role 5 years, and then that role 5 years, you essentially had a guaranteed contract. Was that what you were saying? Is that the trusted legal case?
Yeah, it is. There's been a Supreme Court hearing in relation to this. So
does that mean that all 5 year contracts, all situations, is it because you had 5 years or because you had 10? Does it draw a question under all the 5 year contracts that we have now with CEOs, or what is the situation?
It's the Fixed Term Act.
What is the fixed term? What is the term to allow a fixed term?
If you have 2 consecutive contracts of over 4 years, that's the legal parameters in this. Yeah.
Perfect. So in your current role, do you have a team?
No, I work with all of the executives on whatever the particular
Okay.
strategic roles.
And are you still on the senior management team?
Yes.
And would you meet regularly on weekly senior management meetings?
Yeah, Ms. Nugent has actually set up the structures that are now.
But are
in
you
place.
on that senior management team that would meet? I presume
Yes,
you
sir.
meet with your senior management team weekly.
Not
Okay.
the operations one.
Not the operations, but
Yeah.
you are.
No, because the projects that I'm doing are of a strategic nature, so I'm not involved in operations.
Okay, so in your role then, so obviously just going back to this infamous report, this was put in 2021, 22, was it? Because you had questions about what was happening. You had
Yeah.
concerns.
Yeah, we did have
Yeah,
concerns.
you had concerns, which is fair.
We
So
did.
you did a report, and so what you're saying is you acted on those, and then you were happy just to leave it aside.
We actually put it together, particularly around the patient safety and the risk issues. There was a whole, what we call a management intervention action plan. So this is whereby we were very clearly stating to this team that they needed support and help.
And just to clarify,
And
was
we
the
reported-
but just to clarify, was the consultant reference there at the centre of some of these questions? Was that consultant highlighted in this report?
I don't think, I think if you're talking about, are you talking about the consultant that you commented on that's on administrative leave?
Yeah.
No, it's
Was there any issues in that area, in that sphere? Any
It's a
questions?
different-
I know, but was there any, had they popped up prior to then, around then? Because I know there's a lot of reports bouncing around.
I'm
but
trying to understand which consultant you're talking about, Deputy, just to be
the
clear.
consultant where we've had issues that's on where either of the consultants, I
No.
suppose, any issue that you might have had.
There's two separate services and two separate.
But was there any issues highlighted in that report that weren't actioned fully, that were
No,
actioned
there's
later?
a-
I
no,
suppose is what I'm
they're
asking.
Not related to that, no.
Related.
And I think, just to be clear, I mean, we had a management intervention, there was a whole action plan team, there was a consistent reporting back to the board in relation to this, and most importantly then, you know, because the actions were taken using the appropriate HR processes to actually address the concerns, because there were very serious concerns, and it was, you know, quite shocking to get that report. But I think we genuinely engaged with the staff to say, we're here, we're going to listen, and we're going to act. Please tell us what you need and what are the issues and concerns. And I think we demonstrated here that we weren't afraid to actually, and the staff have trusted us in actually raising those. And some of them were terrible to hear.
Okay.
But,
Okay,
but
I just-
give
no.
assurance those have addressed. And Ms Nugent has met with the team since, and they're in a much better place.
And just to put it across to Ms Nugent, so with the person that's on administrative leave, what exactly are they on administrative leave for?
I'm not at liberty to discuss this as it's an ongoing HR issue, and I don't want to jeopardise that process. I'm not being evasive, but I don't want to jeopardise it.
Is that person an employee?
Yes.
And then they're also doing third-party work as well, is that?
No, I think that you're confusing that with consultant D.
Okay, with consultant D, is that person?
You're talking about sorry, I just want to be very clear.
Yeah, no, be
Are we
clear.
talking
yeah,
about the
I
examination report?
Yes.
They are no longer in CHI.
So they're no longer, were they an employee of CHI?
Yes, they were.
And that they were also doing third-party work, is that how it worked?
When you say third party, do you mean NTPF?
No, just were they doing consultant, outside hours work as well?
They-
Sorry, what I'm trying to talk about, maybe just clarify, talking about the consultant that was working, that wasn't fulfilling the out-of-call hours, but was actually working weekends as well.
Yeah, so the consultant was signed off from on-call commitments, as we
Yeah.
said, night.
Sorry, was that person an employee of CHI?
Yes.
And he's no longer?
No longer.
Okay, so when was that person no longer with CHI?
I think
2022.
2022.
Okay, so and were you, Fiona, would you have been aware of all that? When did you become aware of that then?
When it was published in the Sunday
June.
Times, yeah.
In June, right? So was that leaked? Was that report leaked, or how did that come about?
Yes, it was leaked.
From who?
It appeared in the Sunday Times. I don't know who
So it was leaked
leaked
from CHI, was it?
I have to only assume it was a very confidential report, so only a small
So
number.
who had access to that report?
I would have to defer to Ms Harden.
Ms. Hardeman, was there someone on your team, on one of your previous teams that would have leaked that, or how would that work?
Well, I don't know who has leaked it, Deputy, but the circulation was limited to the board.
How many people would have access to that report? Because was that done to undermine the management team?
I don't know the purpose of that, with the reason for the leaking. I would say 20, I'm guessing 20, 22 people might have had it.
Would you think it served a positive purpose for it to be leaked?
I think, no, obviously the contents of the report, as we have all read them at the time, are appalling and shocking.
Are you happy that it was leaked, Fiona?
No, Deputy, no. I would have preferred to get a copy myself.
You would have preferred, so
In
do you feel
relation-
that,
in relation to
do you
the issues
feel
that
now,
pertain-
would you feel that it was hidden from you and that it should have been? Do you feel that the CEO was neglectful in not sharing it with you?
I think Ms Nugent has clarified that CHI regrets that they hadn't sent us the report at the time.
You feel that they were
And I
neglectful?
accept
Sorry,
that.
I'm asking what's your view on it? I know she regrets it, but what do you think?
Personally, I would have
And
preferred...
that's the same to Don, actually. It's not just for yourself, it's for both of you.
Yeah, we would have preferred to get a copy of the report that pertains to the NTPF. It would have been preferable to receive a copy of that.
And just with someone working out of hours, do they use the services provided by the hospital? Do they do it on site in the hospitals?
Yeah, just to be clear, those clinics were supposed to be off-site, because of COVID.
Yeah.
And that limited the type of patients that could be put onto it because there was no extra.
Just to ask the question, do they use the hospital?
Yeah, no, like all of the insourcing. Like
And do they pay the hospitals for use of, because they're essentially they're private operators essentially at this stage. Are they,
that isn't the arrangement. I mean,
so the arrangement is so they get to just get the money, they don't pay rent essentially like a business would. They just get to use facilities.
These are inpatient initiatives that are progressed by the hospital. It's not by the consultants. So the operations team and the schedule.
I know, but at the same time, they're earning money as an independent operator at that point. So,
all of the
yeah.
staff that are in those clinics are actually being paid over because they're working outside of their normal contracted hours.
And just switching back over to Fiona, one last question, if I may. In Naas Hospital, is the standard, did you say, and I just want to clarify, did you say the standard cost is €200? Have you identified a standard cost of €200 that should be paid to consultants for seeing a patient? Is that what you're saying?
Yeah, no, not to consultants, Deputy. We never pay consultants
No, I know you
directly
don't,
to the
but somebody in
hospital.
Naas has.
Yes.
So I know exactly what you're saying. So I'm just asking, have you identified a standard cost of €200? And what you're finding is a standard cost, but that's the amount that's been given directly to consultants. Is that what the issue is?
Correct. To the best of my knowledge, that the hospital paid the consultant direct rather than using the funds from the NTPF to pay all the staff that were involved in the initiative that was agreed.
And I just do want to clarify that. So you're saying there should have been a team of staff given the money. I just want to find out exactly what the problem is.
This is to the best of my knowledge at the moment, Deputy.
Yeah. So you're not clear either. That's what I'm saying.
That's clarification that I have sought further. So we agree the €200, which covers the consultant, it covers the cost of the clerical staff that check them in overtime, and potentially nursing staff, because you need a team if you're going to run an initiative at the weekend. And the €200 goes to the hospital to cover all of them. But it is my understanding, to the best of my knowledge today, Deputy, that the hospital are paying the €200 directly to the patient, to the consultant.
To the consultant. I know, yeah, no. There's a lot going around here. Strictly. Thanks very much.
I think Deputy Arda asked when that piece of work is done, when that report is completed, that
It will be public knowledge, Chair.
be public knowledge, and we'll get a copy of it at that point. Thanks for that, Ms Brady. Our next speaker is Deputy McCall.
Good morning, and thank you for being here today, and thanks for the work that you do, because as other speakers have said, the scale of even the issues which are here before us is vast, and so the scale of the work that you do outside of all of that, just to acknowledge that the nature of this committee is that we focus on things that go wrong, and so I just want to highlight that. I suppose it's really unfortunate, as Deputy Ardagh says, that you are here before us today in a reactive way, and that's not the way we want to do our work. Unfortunately, CHI have been at the centre of a controversy which involved the implantation of unapproved products in children. It is involved in controversy relating to surgery that may not have been required or was not required for children, and then at the centre of controversy regarding waiting lists and the National Treatment Purchase Fund, which Deputy Geoghegan has said has gone on now to have broader consequences. There's a broader question there about governance that I want to give you a moment to think about, and I will return to the end. We have to get CHI right in order to ensure that you're not before us again in reactive ways. I think the way the other deputies have highlighted that is by doing it in transparency. And if there's a message for your board, who are not here, is that when issues come before it, you have an obligation to inform the other partners that you work with, the HSE, the Controller and Auditor General, the NTPF, and so on. So I just want to focus on the issues of the surgeries that took place and the different thresholds used in Crumlin versus Temple Street and Kappa. How many of those cases, Ms Kelly, you mentioned how many of those cases are being reviewed at present?
I'm not directly involved in the management of orthopaedic surgery, but to my understanding, there's the audit that was published, that there is, the HSE have now committed to doing a review of the children that have had surgery since 2010.
And do you know that number?
I believe it's 2,000.
Yeah.
Yeah, thanks.
So there was originally 2,259 children involved. The children who had surgery in Crumlin, bar one patient, was deemed to have compliant surgery, for want of a better word. So that was 446 children. So the only requirement there is that they're followed up to skeletal maturity till their bones fully mature, which is a routine practice, and that's been done in a normal outpatient activity. The remainder of the children are being seen, as I said, through a multidisciplinary team clinical review to establish the status of the children's hips now, and that involves Temple Street children and Kappa children. And then subsequent to that will be this expert panel.
Can you give me the number where it was deemed to be inappropriate, where the treatment was deemed to be inappropriate?
Well, again, there's just over 1,800 children being reviewed, but in that cohort of the audit, some of those children in Kappa and in Temple Street were compliant. So
my question is those that were not compliant. So I might give you an opportunity to give me that number, please.
Well, I suppose that will be determined because there's only 147 children in the audit.
It's not yet known. So my question is, of those that are not yet known, a difficult question to answer, are we examining if those surgeries were funded by the National Treatment Purchase Fund in any way?
Yeah, none of those children were funded through the National Treatment Purchase Fund.
So you can reassure the committee here that there was no perverse financial incentive for these surgeries to be carried out.
And Deputy, I understand why you're asking me this question, because it was there was a suggestion in one of the media articles that this was a driving factor. When that came to my attention, we did through the HYPE basically, what's the word I'm looking for? Anyway, we're able to analyse the fact that in one of our institutions there was 25% of those patients were private, and in the other institution 26% of the patients were private. Under the old contract, you are allowed to do between 20 or 30% of your activity as private, depending on the type of contract you're on. So there is, based on that, there's no suggestion that this was done for financial gain.
Okay.
There was
and as part of the review, is that being monitored in any way, or because we want to have a public airing of that assertion that you put here. We want to ensure that there was no financial incentive or misuse of the NTPF in order to carry out surgeries which were deemed to be unnecessary. And you understand why I'm asking that question?
I understand why you're asking that question.
Yeah. So my question is that financial element the subject of the review, or is it purely clinical?
It's purely clinical.
Yeah. Okay. So can I maybe turn to Ms. Brady then? I suppose it is concerning, given the breaches that have happened in the MOU, that concern would arise. Is there a way that you can establish that there was no perverse financial incentive for operations which were carried out and were not needed?
Thanks, Deputy. No, unfortunately, I wouldn't be able to establish if there was any perverse incentives. I know Mr. Gloucester mentioned that yesterday in his internal review. There has to be trust as well between ourselves and the public hospitals. We trust them to implement the initiatives that we have agreed on with the agreed price and to follow our MOU. And they, in turn, trust us to pay them for the work that is carried out. So there has to be an element of trust there. So unfortunately,
I don't take away from that. The centre of many of these allegations are individuals who made decisions that are indefensible in many cases. And I suppose we're asking you to respond not on behalf of the individuals who made who did those things that were wrong. We're asking you to respond to the system that can ensure that they won't happen again and that there's checks in place. So you're saying that there's no particular checks. You rely entirely on the medical, on the clinical leadership in those cases.
The operational management of consultants and waiting lists still lies with the public hospitals themselves and the management in the public hospitals.
What you might be responsible for, though, is any potential conflicts of interest, and obviously Mr. Gloucester raised that in his report. What measures have you put in place to prevent conflicts of interest?
I'm not sure, Deputy, in relation to what you're asking.
Well, I suppose there is a question. If somebody is managing the flow of work through a public list, and there's also an NTPF process where they would receive additional payments for work carried out through the NTPF, that is a conflict of interest.
Well, from my perspective,
the clinician is managing the flow of treatment in a public list, but they have an ability to benefit financially by treating that person through an NTPF initiative. I would regard that as a conflict of interest. Now, it may be difficult to avoid that conflict of interest, but my question is, what steps have you taken to ensure that management, if you want to put that word, or mismanagement of the public lists doesn't take place?
I suppose it's down to our process, and it's about the adherence to our MOU. I might just bring my own personal experience into this, Deputy, from managing our Drogheda Hospital for 5 years. Any initiative that came on my desk that was over and above what we would normally ask consultants to do in a core working week, I would have all their work schedules and I would review that with the clinical director before I would ever request that any NTPF activity was carried out within the hospital. And I would assume, to the best of my, that is happening. I see Dr. Kelly is nodding there, that's what should be happening. We must max out what's happening in core hours. Mr. Gloucester alluded to that many times yesterday, and I would completely concur with that.
Yeah. So I think that concern lingers now in the public, given all of the discussion, that in some way those people who are responsible for managing the flow of work through public clinics are in some way organising that work in a way that other colleagues or they might benefit financially from it. And I suppose my question is, what steps are you putting in place to make sure that doesn't happen? Now, you've given me a personal example, I appreciate that, but do you understand that is a very significant concern?
Absolutely, Deputy. I completely do, and it was very upsetting for us in the NTPF to understand that this had happened in several hospitals. So, apart from the adherence to the MOU, it is my intention now, following my national assurance audit, if there are any further NTPF initiatives in relation to insourcing only, is that I will be writing directly to the CEOs or the general managers of those organisations and asking them, before we approve in principle that agreement, that they provide me with further assurance that this has all been done out of core hours and in line with the national financial regulations.
Look, in some ways there's so much stuff to be discussed, but I appreciate the response. Ms. Hardiman, I just want to return to your own case and your own employment contract, and it's unfortunate that you are here as an individual, but you're also responding to what I think is a system-wide issue. If somebody is able to accrue a contract of indefinite duration, which they have an employment right to do over 2 terms, it does call into the question then the minister's, the sense around the minister having an ability to prevent a 3rd term, and you're essentially setting up a scenario where you could be putting, there's no real benefit of having a term limit if the people automatically accrue an employment right over those 10 years. So I just want to clarify one point.
But if I may respond to that, because we would have this as an employment issue within as an employer.
Of course, yeah.
There actually are ways, because you have specified purpose contracts which actually are not fixed term contracts and not under the thing. So I think the system has acknowledged that there are ways.
So would you accept? So Ms. Nugent, is Ms. Nugent are you under the same type of contract? Are we going to be facing the same scenario at the end of your tenure period? Should you serve that term? I do apologise for misusing that word, for serving that term. Apology, Ms. Nugent.
Well, Deputy, let's see how I am.
No, but the question was, do you have the same contract?
I have, yes.
Yeah. So there's a systems-wise issue there for the department, for other public bodies, that we're essentially having to resolve what should be a specific purpose contract, but they're in place as a CID contract.
I wouldn't be eligible for a CID.
If you were to serve the 10 years?
Yeah, well, I don't think I would do 10 years.
Okay, I'm out of time, unfortunately. I'll come back in the second round, Chair.
Thanks, Deputy McAuliffe. Our next speaker is Deputy McGrath.
Very much, Cahier, look, and thanks everyone for being here. And I'm the last in the line, so apologies if there's some repetition. Can I just take a step back and go back to the 2021 report? What actually, can you just clarify what sparked that report?
Thank you, Deputy. I think I'll take that one.
Yeah.
So over the 2019 and 20, there was several issues coming up around this service. They seem to be around operations, like, as in how the function and the services. So in early 21, we put in an operations manager to specifically work with them to work through the issues, and because they were being raised. That manager came back to say there's broader issues here. There's a team dynamics, there's culture issues, and there's unprofessional behaviour issues.
Okay. And specifically concern around
the team.
Referrals to private practice and so on?
No, how the team were functioning. How not functioning, if I was to put it that way. So we met with the team. We as a management team went to the team and said, like, are there issues here? And they did admit, but I said, but they weren't about to open it, so they agreed that we do an exploration. And I offered them, they say, well, some of these are long-standing, we haven't had them addressed for years. I said, We are committing to addressing these issues. You raise what those with
So can I just
confidence,
specifically,
we will address them.
when were concerns raised around referrals?
Oh, this particular issue just in the clinics, I presume
Yeah,
you're
to
referring
private
to,
clinics,
yeah.
consultants working in the public system and references to private clinics.
No, I think Ms Nugent has clarified this, and
Yeah.
apologies, there was no private clinic involved in this element. That was, wasn't correctly reported.
But private
Deputy.
work, sorry, private work.
No, it's not private work. This is,
Oh,
No, so I think just to clarify, and it's not an independent third party doing it. So when we ask our staff to get involved in a waiting list initiative that's funded by the NTPF, our operations team submit the proposal, etc. They organise the clinic, and the staff are paid through our payroll. So there are staff doing extra hours.
so it's out of hours work?
Yeah.
Yeah. You don't classify that as private work?
No, because they're public patients, and as I say, it's like an overtime, as opposed to a private clinic, which would be fee
You
per
can
patient.
understand the incentive to not reduce down the public list as such if you're going to receive out of hours work to...
No, because you must fulfil your contractual hours in your work plan first before you're eligible to do any extra work.
Yeah, I suppose it's the efficiency of that work
Yeah,
plan is what you would question. Like, how many investigations are underway or have been undertaken in this specific issue at this stage? So the HSE itself is looking at it, CHI is looking at it, the
In relation to NTPF?
Yeah.
Mr Gloucester is doing an internal audit of CHI governance and equity of access for our waiting lists, which we welcome because it'll be either reassurance or we'll find areas for improvement.
Okay. Can I just try and get a quantum here? What is the quantum? What is the value of effectively the insourcing that was done? We say if you go back to the 2021 report, which I know you're saying wasn't specifically on this issue, but what is the quantum? What kind of value are we talking about here?
So CHI has received from 2020 to 2024 8.65 million from the NTPF. That's enabled 2,808 children receive inpatient or day case treatment, and 18,644 outpatient appointments.
Okay. And what number of staff would be involved? We're not just talking about consultants here, we're talking about a range of different staff. What kind of quantum are we talking about there in terms of the out of hours work?
It would depend on the type of clinic that's been held, firstly, because, for example, if it was a cardiology clinic, you would have a cardiophysiologist do the tests. So on average, you'd have a consultant, a nurse and an admin person.
And in total, are we talking about dozens of individuals in total?
In the quantum of those years,
Yes.
I wouldn't have that figure.
But it surely is, you're not talking about the same cohort, we're talking...
No, it's sorry. This is across a range of specialties where there is waiting list issues.
So we could be talking hundreds of different personnel over the years?
I would have to qualify that for you.
Yeah. But it's not outrageous to suggest it could be hundreds?
No. But again, I'd like to refer back to you on that.
Okay.
Rather than guess.
Okay, and can I just go back to the individual who was deemed not suitable to be on call, but was deemed suitable to do the out of hours work? How long did that particular issue last? In other words, that they were deemed unsuitable for one form of work, but suitable for another form?
So the individual was reviewed by occupational health and were signed off to not do on-call, which would involve getting up in the middle of the night, having to treat sick, etc.
How long did it go
So
on for?
I don't know the exact figure. I think it was in the region of 3 months or so, but Ms Hardin may be able to clarify that.
I'd have to check it.
It's a number of months anyway.
It's a number of months, yeah.
Was there only one individual in that position that wasn't suitable for regular work but was suitable for out of hours work?
There would be at any point in time a number of staff who may or may not be able to fulfil their full contractual hours due to a gradual return to work following an illness, or in relation to, either having an underlying condition, etc., that may either...
Specifically, they're deemed suitable for out of hours work but not regular work.
Because it's daytime work as opposed to nighttime on call.
I understand that,
Yeah, I wouldn't know that figure.
We don't know if there's more than one individual in that position over the years.
I wouldn't know that.
We don't know that, okay. Can I just go to the former Chief Executive and that issue, and Deputy Neville asked in relation to the background and clarified some of the issues there, I suppose. In terms of the strategic role you now have, when you were Chief Executive, is it documented anywhere or recorded anywhere that there was a role like this to be created during your tenure as Chief Executive?
This was at the board clearly had strategic objectives, and they were identified and brought to the board, and every year it was identified that this was work that needed to be done. The role wasn't specifically done. I think the focus and the emphasis had been very much on managing the hospitals, merging them, dealing with the issues that we're dealing with, and obviously two of those
When
years were
specifically was the idea of the role muted, of creation of a position?
I think the board identified that there was work that needed senior leadership to actually focus on.
A new
and that's
position
what-
to be
and that's-
created.
And because it's a contractual matter, Deputy, so it had a contract of indefinite duration, and I think they
So
identified.
it's fair to say it
be
was
honest,
throughout
they were
this,
saying-
it was throughout the mediation settlement process.
And to give dues, I think they were saying they did want to retain my skills and expert and skill set actually to bring to this, because we have a huge amount of work to do with this huge opportunity that we have the new Children's Hospital coming on board next year. And it is important that some of these big core policy and strategic imperatives are actually addressed.
But just to clarify, the position, the issue of the role being created was never documented anywhere prior to your settlement process?
It was part of,
No.
it would be
Okay.
part of work that was there, but not a role
And,
specific.
and look, again, you went through a chronology in terms of sick leave and admin leave and so on. I presume you were paid throughout that entire period?
Yes.
Your full salary, yeah, okay. Can I just ask, do you work closely with the current chief executive? Are you working closely on a day-to-day basis?
With Ms.
Yeah.
Nugent?
Yeah.
Yeah, I work on the strategic, not on the operation side of things, on
Yeah.
the projects, yes.
But do you work closely?
I'm on the executive team.
Would you have several meetings a week, or?
Well, we would, at the executive meetings, yes, and
then there's a monthly-
There's every 2 weeks, and then there may be other elements, and of course one-to-one
You'd
meetings.
have a close working relationship?
We're very professional, I would say, and the fact that we're two women helps.
Okay. And look, it was clarified earlier, if I can go to Mr. Fitzpatrick, in relation to the costs, the legal costs for the settlement. I understand you said a figure of 120,000 for Ms.
100,000
Hardiman.
plus VAT, so 123.
And that was from Ms. Hardiman's legal team?
Correct.
Can you give us a figure for the legal team on your side, on the CHI side?
Not specifically. We can revert to you on that.
Would it be of that order, do you think?
I prefer to revert.
Can we get any indication today in terms of the legal costs that were involved on the CHI side?
Again, I prefer to just revert in specific cases.
Were there other costs involved, other consultancy, mediation services, outside external services?
Not that I'm aware of, but
You think the only cost involved in this process was legal fees? Were there other professional services engaged in any way?
not that I'm aware of. But I wasn't part of the mediation.
Can anyone clarify that?
Ms Harden may be able to, but it was a confidential process with the board, so the executives wouldn't have been privy to it.
Okay, can we get clarification at a further point on that? I think it's important, if you revealed over 100,000 for legal fees on one side, I think it's important we get the full picture in terms of the costs involved in that settlement mediation process. Can we have agreement that we get those figures? Okay. Can I just turn to the new hospital? When we had you here the last time, you indicated the handover between yourselves and the development board. The handover was expected to be in June of this year, September of this year, with operation likely to take place in June of 26. Are we still on track for that?
That is we are working to the date that we are given. Obviously, we're reliant on the MPHDB and BAM to confirm if there's any deviation from that.
So at this point, we are of the same view. We're hoping to start treating patients in June of 2026.
We want to treat them as soon as possible.
I know that's not answering the question.
That is the date in which we are working towards at the moment, yes.
We are expecting that to come true. Okay, thank you, Chair.
Thanks, Deputy McGrath. A number of questions now myself. Just firstly, in relation to the opening statement given by yourself, Mr. Gallagher, there, just from the National Treatment Purchase Fund, you say that the NTPF first learned of the internal CHI report outlining the misuse of NTPF money at CHI. Do you stand over that comment that there was? Is that an established fact in your view that there was a misuse of the funds?
No, it depends on at that point in time, that was our then belief. Do you want to add to that?
So, Deputy, when we learned about it in the Sunday Independent, Sunday Times, we were very concerned because the allegation was there of misuse of funds and we knew nothing about it. The following day, I liaised with Ms Nugent and we had a conversation in relation to what the issue was. I made a request on the Tuesday then for the report just that pertained to the NTBF so we could get an overview. And unfortunately, Ms Nugent wasn't able to release that. And it was at that stage I wrote to her to say I'm going to stop all insourcing until I get an idea of what we're talking about here.
But just that particular word, use of that word in your opening statement, where you don't say alleged misuse, you say the outlining the misuse of NTPF money. So it is misuse, or
No, Deputy. When I got a copy of the redacted reports that just pertain to the NTPF, I reviewed it in detail and I realised it wasn't a misuse of the NTPF funds.
Okay. Can I just, Ms Nugent, the last time you were in, you weren't aware of this unpublished internal review at that point, and you stated that the first you heard of it also was in the media over the course of the week.
When there was a media request came in on the Friday night, Saturday.
Okay, so you were blindsided by this, it would be safe to say? Yeah, absolutely.
Since then, though, I have asked all of my executive colleagues and my consultant colleagues if there are any other reports outstanding that I need to be aware of.
Okay, and are there any?
There are some minor HR ones. There's some actual reports where staff have sought the intellectual expertise in planning for the new hospital, but I don't think that's relevant to what we're talking about here, but it was good to see.
Okay, and Ms Hardiman, obviously as part of that internal process, have you been asked as to whether there's any outstanding HR issues or reviews or reports that maybe in hindsight should have been brought to the current CEO or the then acting CEO? Is there any other?
No, I've shared with Ms Nugent.
Okay, so
thank you.
So we're not no one's going to be blindsided at any point.
No.
No.
Not. I think I've told her.
Okay, just in relation to the unpublished review, a number of deputies have touched on what triggered it. Was it a whistleblower? Was it staff that first raised the issues, or?
No, several members of this team were coming to several other members of the executive with issues. They seem to be predominantly operations, and as I said, we put somebody in to work with them specifically. She came back and said there is more to this than that. There are long-standing issues, and particularly team dynamics and unprofessional behaviours, that warranted exploration from a HR perspective. So that's why we assigned then somebody from a specialist, from HR and operations, because we knew they were connected. And that's what led to the review. And we agreed the terms of reference with the team of consultants and asked the staff to please just be open with us, because we know there are issues here and we want to address them. And that was the important trust matter. And I think that's where we actually gained their trust because we acted. And we followed up with the HR process. We put in the management intervention plan. We addressed the patient safety issues. We reported it to board. We took the issues up through the HSE, not the report itself, because we want to maintain it confidential. And I think I can confidently say that's a better service.
Those issues that you say you brought to the HSE, would it be possible?
And they helped us. Most of them were investment issues that we needed actually specific investment.
I suppose that review itself, the findings of that review was never furnished to the HSE.
It was never meant to be.
Can we get a copy of exactly what was sent and who it was sent to?
Yeah, the issues that we raised, yeah, absolutely.
Okay, thanks for that. And just in terms of the particular individual who I think it has been stated that, you know, they were operating this system of working on a Saturday, not honouring their contract, and that was about 3 months in duration. Is that what?
Are you talking about how much they were signed off by occupational health?
Yeah, how long were they?
I'd have to find that out.
We don't know how long.
Oh, that period, yeah, that was a short period. That was just the end of 3 months, I would say.
About 3 months.
5 clinics.
And
so
has it been
5 Saturdays.
established as to what the financial cost of that was? I mean, how much was that consultant getting paid or did get paid over that period of time?
The figure for working the additional hours, is it? Yeah, in 35,000.
35,800 or?
Yeah.
It was actually slightly
It was
less.
slightly
It was
less.
actually slightly less.
Yeah.
Okay, so
35,800 was approved back in
35,000. So that's over a 3-month period. So
For
you're-
additional work taken,
additional
over
for
and above their core hours.
working
yeah.
on a Saturday over 3 months.
And
so
that's the arrangement of the insourcing that,
Okay.
that
So
has been referred to
you're looking
across
at
the system.
€3,000 a week, €3,000 approximately for is it?
£7,000 a clinic.
£7,000 a clinic. Is that how much per clinic was?
It's just the overtime paid to the consultant in respect
How much
of-
per clinic was he getting?
I don't know per clinic, but in respect of NTPF work over the period.
It was the hours worked.
Yeah.
The hours worked. Okay. And how much per hour would?
I wouldn't have that figure.
Could we get that
In
figure?
accordance with approved consolidated pay scales.
Okay, can we get that
Yeah,
figure
sure.
Furnished to us? And it's being stated here that consultant is no longer an employee of CHI. Just again, did that finish in 21 or 22? When did?
In 22.
22, and was that of that individual's own volition, or was that the result of a HR?
Yeah, we can't get into the specifics, but what I can say is that some staff did leave as through HR processes were actually implemented. Yeah.
Okay.
And others were, supported and developed to actually address, and in particularly there was like organisation psychologist support put in to get the team dynamics and support the team so that they could, function better as a team. So all of those supports put in and the relevant HR policies were actually implemented.
Okay. Was there any disciplinary actions taken on
Some of those, yeah, that's what I'm talking about, grievance, disciplinary,
Okay.
all of those elements, yeah.
So
But I can't get into specifics because I think that would be unfair and potentially.
was it a mutual agreement, that individual leaving then?
With the HR process are the HR process, and you have to work through them.
Okay. Just in relation to, there was 2 different percentage figures given earlier on by the CNAG, and I forget who gave the one, just in terms of the breakup between the public and private. I think the CNAG said that figure breaks.
I mentioned 60-40, and I think the chair of NTPF mentioned 70-30 in 2024. Yeah. So I was talking about 2023.
Okay.
This was 2024.
Just to clarify that. No, thanks for that. Just in relation to the 27-month review in terms of that was carried out for insourcing. A figure of 100 million has been given across the HSE for insourcing. Do we know how much CHI, for over that 27-month period for insourcing, how much has that cost?
Which year?
As part of, there was a review carried out by the Minister, and Bernard Gloucester, I think, made reference to it. He published that review.
Is this the one that was published on the 1st of July?
Yeah.
I wouldn't have the breakdown of the figure here with me. I have what we received from 2020 to 24 by year.
Okay.
If that's useful. So the total is 8655513. Do you want to get in? Sorry,
Yeah, no, from the NTPF, we received 8.6 million over 2020 to 2024 under access to care. We received 28.2 million from 2020 to 2025. And it was that expenditure which I believe was the subject of the report you're referring to.
Okay. And Bernard Gloucester and the Minister have also, at committee and reference, a number of members spoke to, I suppose, the winding down of insourcing, and they've given a date of June of next year for that practice to be wound down. There have been concerns expressed in terms of the ability of CHI and other organisations to be able to meet that deadline. Ms Nugent, June next year, and that practice, which I think, has opened a lot of concerns and issues and pitfalls. Do you think that target is achievable?
That's something that myself and our new Chief Operations Officer is reviewing to actually see what is achievable.
Okay. Is it achievable, do you think?
I'll know when the review is done.
Okay. You might come back to us on that. Now, Bernard Gloucester also said there's an over-dependency on insourcing. Would you agree?
I think one of the challenges for paediatrics specifically is that there's very little paediatrics in the private sector, number one, and a limited number of paediatric hospitals in the country. So there is probably, it's slightly different to adult hospitals where there's more choice. So that is probably one area that insourcing has supported us in trying to reduce our waiting lists.
Okay. And audits being carried out on insourcing? What nature or how often or
so the NTPF would regularly carry out audits of all hospitals. So we had, I think, 2 in 21, 1 in 23, 1 in 24. But as also part of our own board assurance process, the internal auditor did an audit in 2024 that found that our waiting list processes were robust and in line with NTPF guidelines.
Okay. And just in relation, we got examples of 2 private hospitals earlier on, just from funding from through NTPF. Do we think it would be useful from a transparency perspective that all hospitals' figures receiving funding would be published and readily available? Ms. Brady or Mr. Gillen?
It's not something we regularly do, Deputy, but I don't see why it can't be. I don't see any reason why we can't. And we have the figures readily available.
Okay, well, look, maybe if you could furnish this committee with those figures, maybe over the last 5 years from 2020 through to the 2024.
That's all public and private
all public
hospitals.
and private, yeah.
That's fine. Yes, definitely we'll do it.
Okay, just to conclude, just briefly in relation to the hip dysplasia, and earlier on I think reference was made to surgeons, and I think Ms. Nugent, I don't know whether I picked it up right, you said that all surgeons are still working, and then later on I think we were talking about Surgeon A then, who was out on gardening leave, so I'm not sure as to whether...
You are correct in that individual is on leave.
Okay, and just in relation to, I suppose, the hip dysplasia and parents being offered second opinions, and we have some of the figures in terms of families and children still undergoing review on that. How many parents or how many cases have sought a second opinion at this stage? Do we have any?
I don't have that number to hand.
Maybe
as an external to CHI?
Yeah.
Yeah. No, at the moment, obviously, we have, there's a process for the review, and then there'll be the secondary commissioned expert panel. I don't have that figure to hand.
Okay. Would you be able to get that figure?
I can certainly, absolutely.
Okay.
Sure, yeah.
And just in terms of funding parents to carry out, to get that second opinion carried out, is funding being put in place?
Sorry, I know that Mr. Gloucester and also Dr. Tom Henry said that funding would be made available.
It will be made available.
That's what they have stated, yes.
And just in terms of, you said you were looking at the, I suppose, all of those cases being reviewed as to whether there was a clinical need for the surgery to be carried out. Are you also looking at whether it was necessary to carry out the surgeries?
This is a HC commissioned review, and it's to assess the decision for surgery or not, is my understanding.
Okay, just to assess the decision for surgery, not to assess whether the surgery was necessary.
I suppose it's an interpretation of words, isn't it?
Okay. No, it's my understanding that surgeries, that families need to know whether the surgeries were necessary or unnecessary.
I understand.
And I think, I think families are very unclear as to what that process actually looks like and what the outcome will be and what is being looked at. And I think clarity is needed on that front.
And Dr. Henry in the Joint Doctors' Health Committee with us 2 weeks ago advised that the expert panel is being established, the terms of reference, etc., are being drafted, and that he's going to communicate that as soon as that has been finalised.
Okay. That's myself. Now, I'm conscious members may have a number of supplementary questions, and I'm sure there are, and I know you're probably under time constraints, so if agreeable with yourselves, I'll limit members to 3 minutes, and of course if any of our witnesses need a comfort break at any stage, there's no issue there, so just indicate or let us know, and we can suspend proceedings at any point. So I'll go back to our first speaker, which was Deputy Boland, 3 minutes.
As a lawyer, I think it's really important that I just state that it is not an absolute employment right that two contracts equal a contract of indefinite duration, particularly if there is objective justification. And I assume, given the hefty amount of your legal fees, that it wasn't accepted, and it was settled on the basis that your position wasn't accepted. Can we just be clear on that? Is that the case?
Sorry, Deputy Bull, can you say, I'm conscious I'm talking to a lawyer here.
So
just repeat what you said there.
You in your evidence earlier, you said that two contracts equal a contract of indefinite duration, and that is not absolutely the case. It's not an absolute employment right, and because you've got on the record, I just want us to make sure that we're clarifying that there wouldn't have needed to be a dispute that gave rise to you having 100,000 in legal fees if your position wasn't disputed.
I'm just taking the guidance that I've been given specifically around
I think it's just important to say that.
And the Supreme Court hearing in 2022 that ruled on this matter that was relevant to my role.
But was it, so there was a Supreme Court hearing?
Yes.
In relation to your role?
No. The posts of group CEOs. So that's where this guidance came, or ruling came from.
But the CHI didn't accept it, or the Department of Health didn't accept it, which is why you ended up in a mediation.
CHI accepted that there's a contract of indefinite duration. It was accepted by everyone that there's a contract of indefinite duration. I think the Act that established CHI says that the Minister has to give consent. The government policy is that a CEO of a non-commercial state body can't do 5 years and no more than a second term. So that's the policy position that the Minister was quite right to apply, and the board accepted it. So we just needed to resolve the issue then, which was a contractual matter.
Okay.
I hope that helps.
Well, yeah, I'm not sure, to be honest. Can I actually just ask you, Ms. Nugent, about the Children's Health Foundation? Are you responsible for that?
No, it's a separate legal entity.
And what is the governance in relation to that? Because I know public monies are given to that foundation, and they have quite a significant sum of money sitting there. And how does that work in terms of how that money is applied towards Children's Health Ireland?
So, as I say, it's a separate legal entity with its own separate board. There is an SLA, isn't it? Yeah, an SLA in between the two entities. And basically there is a process from which CHI can apply for funds for specific projects.
And in terms of the amount of money, there's over 30 million sitting there?
That's for the CHF to answer, if that's okay.
And then lastly, Ms. Brady, you mentioned breaches of the Memorandum of Understanding. Is there any penalty for hospitals who breach the MOU?
Not currently, Deputy, no.
Do you think that some should be built into it?
I suppose it has been discussed at executive and at board, and we're certainly going to discuss again, but in relation to, it's public money and it's in the public system, but it's not something we've made a decision on, but it is going to be discussed at the next board meeting.
And do you feel the hospitals have breached your trust?
Certainly we have felt that, there's no question, but I will emphasise that there is sterling relationships between the NTPF and with the HSE on a daily and weekly basis, and we work really well with them. And I think in the main, while I know we're talking about insourcing and the difficulties, it works really well, and there's a lot of patients who have better quality of life because of it as well.
Thank you.
Thanks, Deputy Boland. Deputy Gagan.
Thanks, Chair. Ms. Hardiman, everyone accepted that you had a contract of indefinite duration. So what was the dispute about then?
I think we needed agreement on what that contract would, that role would be.
But why did that cost €120,000 to work out what the agreement? Did they accept that you were entitled to the salary as a CEO? Was there a factual dispute? What was that factual dispute?
No, it wasn't about, I think the contract of indefinite duration was as accepted. It was what is the role and how does it work had to be agreed.
But you can see why people watching here or listening are trying to work out, like, why does that cost €120,000? Why do you need so many lawyers? If everyone's in agreement that you have a contract of indefinite duration, you're entitled to the CEO's salary of an equivalent scale. Why would it, like, what's going on in those rooms that it took €120,000 to resolve?
And I suppose, Deputy, there was a mediation process. There is confidentiality and in relation to that, so I can't breach that.
And that's fair. And you did say that you'd be happy to waive your NDA, isn't it? Am I correct in that?
Yes.
And can I just ask Ms Nugent, on behalf of CHI, would you be happy for the CHI to waive the NDA in relation to this process?
That would be a matter for the board to decide.
And is that a matter you could raise with the board?
I can raise with the board.
And then who's the third entity? The HSE, is it? You said there was 3 parties to this NDA.
No, it would be the department.
Department of?
Health.
Health. Okay, well, perhaps we can go back to the Department of Health. Who requested the NDA? Was that you, the Department of Health, or the CHI?
No, it was not initiated by me.
So who initiated the NDA?
I know it was called the NDA, the mediation process.
The NDA, no. Who requested there be an NDA? Was it you, the Department of Health, or the CHI?
No, the mediation process wasn't requested by me. It was offered to me, and I said yes.
No, I know
let's do
that. The NDA. I'm just asking about the NDA.
As part of the mediation process, there was an NDA required.
Yes, but there's an NDA dealing with the whole outworkings of it as well. That you couldn't discuss what had taken place or what had been agreed.
Could I maybe just offer something? Having seen a number of settlements, it's fairly standard, and it's kind of pro forma. There's a clause in the template that's used, and I'd say that's where the NDA came
And how does that relate then to the code of governance conducts that we've highlighted in terms of not having NDAs?
The wording of it must state that there can be confidentiality, because obviously there's a HR aspect to it, but it cannot exclude if there's a legal duty to disclose the matter. That must be available under the NDA.
Okay, if I might get 1 more minute, I'd really appreciate it. Just on the medical council referral, Ms Hardiman, in relation to the individual that was the subject of the examination that ultimately retired, was there a great sigh of relief that he retired from you and the board? But did you feel very relieved that that was the course of action that he elected to adopt for whatever the outworkings of the HR process was?
I can't comment on the outcomes of the HR process.
No, I'm not asking you to, but did you feel a sigh of relief? And did the board feel a sigh of relief?
No, I think, to be honest, there was an acceptance across the board and the organisation that this matter was, that all of these issues were being addressed, that they'd been brought to the fore, that they had been put into a process, and that we did get the support of the HSE to address some key concerns and issues. And this is a team that actually is in a much better place and has done some great innovation work, and particularly looking at the model of care, and so it has got to be commended how they've actually turned themselves around.
The report recommended that he would be referred to the medical council, isn't that correct?
I think the threshold for writing to the medical council again it wasn't an issue, because remember, this isn't about a consultant going off doing something themselves. This was about, the arrangements were put in place was through the operations team. I mean, I regret that we didn't actually specifically identify
the
these issues
report,
with
which has been reported on in news publications, expressly states that this could be a matter for the medical council for referral, and you as the CEO and the board took a decision not to make a referral to the medical council.
I can just say is that the relevant HR process were put in place, and I can't disclose any further, but it did not require a recommendation to the IMC. Thank you, Deputy.
Thanks, Deputy Gagan. Deputy Connolly.
I just wanted to go back to the Children's Health Ireland, just in relation to your financial statements. And I meant to ask it on the last occasion, but I ran out of time. Just in relation to legal settlements, and your financial statements clearly disclose in relation to the Workplace Relations Commission and the total sum there of 125,500. But it doesn't give any figures for the ones under the State Claims Agency. Can you just clarify that, please?
So the cost of those claims, so it's
were settled. The 32 claims were settled.
So, there were 38 legal settlements that year.
It's just the 32 with State Claims
we
Agency.
didn't cover the cost of that. State Claims Agency covers the cost.
Do you have any details on that? The cost? You gave us a figure for the WRC.
That would have been a cost incurred by CHI, whereas the cost of the 32 settled by the State Claims Agency isn't borne by ourselves.
Okay, and do you have a figure for it? or the nature of the cases?
I'm sure I can get something as in.
You would be
No,
fully
they'd
aware.
all
I
be-
mean,
they'd be in relation to clinical cases.
Yeah.
Because it's falling under the State Claims Agency, and the costs are covered by the State Claims Agency.
Okay. You'd be able to give us figures on it?
Yeah, and there's regular meetings with the state claims.
Yeah, I imagine so.
To actually, advise and also to make sure there's learnings from
and
that.
to prevent, yeah, but just the figure. But that's the reason why it's not disclosed there. But if you could come back to us with the
If I
figure.
can, as in,
If you
yeah.
can. You might let us know one way or another, because then we'll pursue it with the State Claims Agency. And just in relation to the National Treatment Purchase Fund, I think you've excluded, consultants can't refer from their public to the private. I think you've excluded that as a possibility, have you?
That's correct, Deputy.
Absolutely.
Absolutely not.
Can't happen.
No, and in relation to outsourcing, from a legal perspective, the referring consultant cannot be the treating consultant in any private hospital.
Okay. And it was gone out of my head now, it's the other matter. Yeah, just in relation to private patients. And I mean, I was asking about private patients and the failure to collect the insurance. But actually, the seriousness of having children as private patients, that concept, how many patients would be seen as private patients with an income coming in? It's relatively small, I think, because the figure is 14 million or something.
Well, the income was 10.56 million, and it is an income that's declining because as more consultants take up the public-only contract.
So how does that happen? The family have insurance, VHI or some insurance, and when they're admitted to hospital, they're asked if they have insurance, which really you're not entitled to.
Do they want to use their insurance?
Do they want you put it like that? So what does that entitle to them above a child that doesn't have VHI or whatever other insurance? What's the advantage?
Well, they may have been referred to the hospital through the private clinic and have that relationship with that doctor, so they invariably then, that doctor, the consultant who they...
So do they stay in a private stream then all of the time? No? Just explain to me the difference.
We don't have specified private facilities in CHI.
Yeah,
but
I wouldn't expect that you do. So
yeah.
I've just explained to me then why some people
have private insurance
Yeah.
and they elect to use it when they're...
Yeah, so the advantage to the hospital, I don't agree, public hospital should be public, but it's not, I'm not here to express my views, just to clarify. So the family have insurance and they're seeing, the advantage for the hospital is you're earning money, it's income, however small relative to your overall budget. But
And
what's
then
the advantage for the child? Well, surely all children are treated the same. Sorry. Yeah.
There's no difference. Children are not treated any differently whether they're public or private within CHI. So there's no difference between their treatment.
Yeah, well, that says a lot, doesn't it? That's very good. So yet we have an insurance system as well at the same time, and they're being asked, do they want to use it? But there are no consequences, there are no benefits. Sorry, I'm over
Those families have the option of using private insurance outside of CHI.
So they're getting to be seen quicker maybe outside, are they?
Possibly, but their treatment within CHI is no different.
Garma.
Big Conley, Deputy Dolan.
Gurmagad Cahirlook. On this round of questioning, I'd like to speak directly to the NTPF. So over the last few weeks, I've undertaken a body of work to write to every single competent authority, state body, to see are they meeting their obligations when it comes to publishing purchase order data on their websites. Are you aware of my correspondence to the NTPF on the 17th of June?
No, Deputy, I'm not.
Okay, no, that's okay.
Sorry, no.
So you are?
You.
Perfect. No, thank you.
Beg your pardon.
Yeah, so essentially I wrote to the NTPF, and it wasn't to single you out, it was to all state bodies and entities, and it has been a very fruitful exercise because essentially what has happened is many of the state bodies who have not been publishing their data, yourselves included, now the data may be there but it has not been published on your website. I appreciate you coming back and emailing me to commit to publishing this data, and it is really important. Where I'm going with this question is based on prompt payment data, there may have been about 345 million euros spent within the NTPF over the last few years. And the reason I'm asking this is because if no purchase order was published, it leads me to believe either two things. Either all of the sums or all of the individual payments are less than 20,000, so they fall outside of the remit, or else they're just not being published. So would it be possible for ye to outline who the largest recipients of the NTPF were? And I understand from the earlier questioning that it would be hospitals. would it be possible for CHI to provide us with a list of who their, from largest to smallest, people who were paid out were?
In relation to our suppliers or in relation to outsourcing?
In relation to specific NTPF money. So the NTPF money comes to the hospital. Who did you pay it out to? And can we get a list from largest to smallest of that? And do you have a date as to when the NTPF is going to have its purchase order data online? And I will say you weren't the only public body who wasn't doing it, but I do appreciate your commitment to do it from now on. Do you have a timeline though?
I would say sometime over the summer.
Okay, all right.
Okay.
Just if I may, Deputy, just because I've asked this question in relation to can we understand who is earning what through the NTPF. The problem is because it goes to the payroll as overtime, it's hours, so it can be done, but it is a manual process to do it.
So you don't. So just so I'm clear, nobody is tracking the NTPF money from once it hits the hospital.
Oh no, no, absolutely there is. There's an internal tracking process with the weekly updates. No, there is an.
But right now, you couldn't tell me who got paid the most money from the NTPF last year.
No,
they can tell me which hospital got paid the most, but you couldn't tell me which individuals got the most right now.
We can, but it's an exercise we'd have to undertake.
But that exercise has never been done.
No, but can I clarify also between NTPF and what we call the access to care when you were talking about getting a list of payments to, is it third parties? And just to clarify what the request.
Well, whether it's a company or whether it's an individual, somebody, it's always a Pareto effect. There's a disproportionate winner out of any outcome. So somebody is getting the most amount of money out of the NTPF. Now, they may be providing the most amount of services, but what I'm trying to get at is NTPF gets the money from government, NTPF hands the money to the hospitals, and I don't know right now who benefited significantly from the NTPF. And you don't know.
So your question is purely in relation to NTPF?
I want a list of who the highest earner was from the NTPF right down to the bottom. I know that they can tell me which hospitals got the most, but I want every hospital now to go and tell me who actually got the money, what procedures, how much. And like that's a governance issue for NTPF as well. You should look for that back off the hospitals and say, we gave you 20 million, where did it go? Or we gave you 100 million, where did it go? And can you explain, I apologise, Chair, now I've gone slightly over, but this is really, really important. You said overtime. It goes out in payroll as overtime. So if I'm a consultant working in the hospital and I decide, okay, I'll take on 10 surgeries on a Saturday, that's coming in my normal pay packet as overtime?
If they fulfilled
if they fulfill their core hours first. But in relation to NTPF, we only get paid when the activity is done. So it's literally, it's per patient. So there's no way we can get paid if we haven't done the activity. In the same way, be it the nurse, the doctor, the admin person, cannot get paid unless they've done the hours. There is an overtime, there's a process for claiming overtime.
Just the CNAG?
Yeah, the CNAG. Just.
Chair, it may be helpful to understand that there seems to be two models for insourcing. One is, as described in CHI, where individual staff members are paid overtime, and if there are other expenses, they're covered as part of the normal expenditure of the hospital. But there's also where there are companies who are contracted to provide services. And I think some of those were mentioned yesterday, I understand, by the Chief Executive of the HSE. And he specifically mentioned, I think, 2 cases in Limerick where there were consultants who have companies that are paid for. A second point to bear in mind is that there are 2 sources of funding for insourcing. One is the NTPF, but there's also Access to Care, which is funding within the HSE.
Okay. So I apologise, Chair, I know I'm gone too far now, but is there any related party checks performed on companies that are paid to consultants that are already employed within the hospital structure? So, for example, you have a consultant employed in your hospital, and that consultant simultaneously has a company. Is that in conflict with their contracts? Is that a conflict of interest?
So that would all be declared under the Standards in Public Office annual returns. We've worked with that's a third party survey that was done, and we have no consultants involved in NTPF that is a director. Does that make sense?
You've done that check yourselves?
There was an ask to complete actually by tomorrow, a survey, and so we'd submitted all the payments to third parties, okay, under the Access to Care initiatives. And as a result of that, questionnaire came back to us saying, of all these companies, can you confirm there's no common directors or common employees? And we were able to confirm that. But just going back to a question, might be important just to clarify. Under Access to Care, okay, our employees, so companies come in to undertake work, and our employees may sign up to work with them. And they would receive a payment in relation to that, but not from us, from that external company, and that's an approved process.
And it's ceased. Okay,
Yeah.
so that was, so historically, just for clarification, back in 2020, kind of post-COVID, the dynamic purchasing scheme was established where third parties there was a framework done and third parties could be used to pay staff. Mr Gloucester has asked all entities to cease that unless there's a derogation for specific areas. So we have ceased that in CHI.
Okay, thanks for that. Thank you. No problem. Deputy McGrath.
Yeah, thanks. Thank you all for bearing with us. Can I just go back to CHI and I suppose the report, there were suggestions of a toxic work culture, concerns raised for the emotional and physical well-being of some members of staff and so on like that. How many individuals made bullying allegations during that process of engagement?
I'd have to defer to Ms.
Yeah, it's probably a previous CEO, yeah.
Yeah, thank you, Deputy. Again, without identifying any of the staff involved, but the matters in relation to the trainees was definitely one that we put in supports to actually and actively help. By the way, all of the staff were offered well-being and support, and some of them did actually take that as part of this process.
So how many staff would have raised concerns around bullying and inappropriate behaviour towards them?
I think there was one category, a group of staff where it would have been, like it's not a big department, but so it's less than 5. It's
Okay.
small numbers, but it is a small section of it. And then of the trainees, there was a few of the trainees, and we raised that all again. We acknowledge that the party involved in that is the training body involved. We engaged with them in relation to this. We engaged with the external.
Was there any
specialty
disciplinary action
advisor.
taken against those?
Yeah, no, that's what I'm saying, is the appropriate, whatever was appropriate was implemented.
There was disciplinary action?
Whatever the policy, because there's different HR policies like grievance, disciplinary, performance management, whatever the appropriate policy was actually implemented.
Okay. In terms of what forms of disciplinary action are we talking about? Without naming anyone?
You see, you have to work with people, so the issue here is that
it's more like a reprimand.
No, the big thing here was the team, and it has to be supported to function as a well-functioning.
It's more issues
team.
being highlighted than anyone facing consequences.
So unprofessional behaviours were addressed. They were addressed, and they were not tolerated. And there was a new.
No one lost employment or anything like that throughout the process.
Some people did leave, but again, I can't get into the details of that. But some people did leave
Voluntarily.
No, some people did leave due to the process, and I can't get into it anymore because that would not be fair on the staff.
Okay. Look, my time is tight. Can I just go back to CHI and the issue of the fees throughout the process of the mediation and settlement with the former Chief Executive Officer? I do find it extraordinary that CHI is not in a position to give us some clarity around the legal fees on that. And I just want to give another opportunity. So you were able to clarify the fees on behalf of the former Chief Executive, but we cannot clarify the fees in terms of the legal services engaged on CHI's behalf.
And the reason being is that the CNAG's report refers to a settlement agreement. And I know when we were here last time, there seemed to be some confusion. Was there payment or what? So then I clarified as in, were there any fees of which were paid on Ms. Hardeman's behalf? In relation to, we can certainly get that information.
We will get that information. And can I just clarify, it's not just legal fees, any other external services around mediation, professional services that were involved in that process? Can we clarify the overall cost in that? Because Deputy Gagan made reference to the fact that what was in dispute effectively and why it took so long. And I don't think it just cost 120,000. It sounds as if it potentially cost a lot more. Finally, Chair, if I can, just going back to, I just want to clarify this so I'm 100% clear in my own head. The individual or individuals who were not deemed suitable for regular work but were deemed suitable for out-of-hours work, and reference was made to potentially nighttime calls and so on. Can we just clarify, was the individual in question here, were they not working at all during the week?
They were working their full work plan for the week, Monday to Friday, and they just weren't doing the on-call commitment.
It was just the on-call commitment.
Just the on-call.
So they were doing their Monday to Friday work and then doing the additional overtime on a Saturday.
Yeah.
Okay. It was just the on-call commitment. Okay. I just wanted to clarify that. Thank you.
Deputy McGrath, just a few concluding questions from myself. Just in relation to that particular consultant that was focus of that review and the figure of 35,000 thereabouts has been established. Were there attempts to recoup that as part of the process, or is that?
No, because those were clinics that were set up in keeping with the NTBF processes, and were so the extra work was done, the additional work was done, the kids were brought forward, they were seen earlier and they were treated, so it is in accordance to those processes.
And just, can we get a specific breakdown of those costs, the 35,000, how much per clinic, how much per child seen? So if we could get a breakdown on that. Just in relation to the children, because look, it's been stated here, obviously the children are our focus, our priority, and absolute have to be. But there have been reports that the impact that process had and the delays in children access and treatment, has a review been carried out in relation to the impact that process had? You know, one of the members made reference to, you know, people being, you know, upped on lists in terms of getting access to treatment. Has any review been carried out?
First of all, Deputy, to clarify, these were long waiters. They didn't jump the queue of others per se. In relation to the surgery and the suggestion of it being delayed, my colleague, Ms Kelly, will be able to explain specifically on that. And I'd just like to clarify, it's not an SLA we have with the Children's Health Foundation, it's an MOA, just for the record. Thank you.
Thank you. Ms Kelly.
Chair, so there was 179 children that were seen in those clinics, is my understanding. And these were children that had already, as Ms Nugent said, long waiters. So they'd waited an average of 19 months prior to that, ranging, I think, from 12 months to 35 months. So these were children that were seen at the weekend. They were then brought in for treatment. There was 51 of those 179 that were deemed to need ongoing treatment. So those 51 children were then scheduled for that treatment, all of which were completed over 4 months, which would be an appropriate time for that treatment from the time they were seen.
Okay, there was reference made that that process delayed treatment for some children by up to 3 years. Would that be accurate?
I really can't see how that makes any sense, because these children were seen in additional clinics at the weekend, taken off the regular waiting list to be seen and then treated.
Okay, you can't see that, but
No.
has a review been carried out to establish that?
Well, that was part of the report that was done back in 2021-22.
Okay,
Yeah.
so there was no impact there. Okay, well that's all the questions I have. I want to thank you all for coming in again today, and that includes our engagement with Children's Health Ireland and the National Treatment Purchase Fund for today. I would like to thank Ms Lucy Nugent and our officials from CHI for attending again today. I also want to thank Mr Don Gallagher and his staff from the National Treatment Purchase Fund for attending and assisting the committee today also. Is it agreed that the clerk seek any follow-up information and carry out any agreed actions arising from the meeting? Great, thank you. The committee will next meet at 9:30 a.m. on Thursday the 10th of July 2025. The committee will engage with the Accounting Officer of the Department of Public Expenditure, Infrastructure, Public Service Reform and Digitisation from 10:30 a.m. To examine Vote 11, Office of the Minister for Public Expenditure and National Development Plan Delivery and Reform, Appropriation Account 2023, Vote 12, Superannuation and Retired Allowances Appropriation Account 2023, Vote 39, Office of Government Procurement Appropriation Account 2023, and Vote 43, Office of the Government Chief Information Officer Appropriation Account, and 2023 report on the accounts of the Public Services 2023, including Chapter 3, Vote Accounting and Budget Management. The meeting is now adjourned. Gorb Míle Mág.